my pleasure to moderate these two sessions with Dr. Osamu Ida from Japan. Osamu.
Nice to meet you. My name is Ida from Japan.
And so the first topic will be about dogma. And so behind this, it is the dogma of no stenting zone. And we will have a great debate between two very famous interventionalists, Mario Palena. Hello, and you start by the, or Dr. Langhoff start, I don't know. We start by Dr. Palena, Dr. Langhoff. You can start, let's go. And so you are, in this case, a pro-stenting.
So good afternoon to everyone. Thank you, Yang and Osamu, for the introduction. I'm pro-stenting in popliteal artery. This is my disclosure. Well, let's start with the question. Is there actually any indication for stenting in POP? I personally believe yes. This is a case, a very complex case. Old patient, diabetes, dyslipidemia, hypertension, multiple comorbidities, CLTI of the right limb with a previous transmetatarsal amputation and ulceration. What I did was an antegrade access in the common femoral. You can see from the puncture to the closure, the patient was already treated because you can clearly see the previous, there is a pointer, yeah, the previous closure device here. So I did a new access downstairs, 1 centimeter down, and CO2 angio that show a patent SFA, re-occluded popliteal artery, segment P2 and P3, and direct flow in the peroneal, but no anterior, no posterior, and still very bad flow for the foot with some branches of plantar arteries, but yeah, not a good flow. So I approach again with a 4 French catheter and an 018 guide wire popliteal artery. Crossing was not so difficult because the artery, the occlusion was already treated previously. So thinking more about recoiling rather than hyperplasia. Approach also of posterior tibial. You can see the guide wire advance in a lumen for a while till the ankle level, and finally I make the loop. And with the loop I was able to reach the foot, reach the lateral plantar artery, re-enter there, and finally go down in the middle of this calcified lateral plantar artery till the arch. This is still the 018 guide wire, so 018 platform balloon, 2 millimeters for the foot, 2.5 for the posterior tibial, and I did a full dilatation of the foot arteries, the lateral plantar, and I did with the same balloon a pre-dilatation of popliteal artery. You can see it was relatively easy to reach the foot, the arch, and to cross completely the arch without needs to push more in the dorsal circulation. So angioplasty of lateral plantar, angioplasty of posterior tibial, 2.5 and 3, finally, to improve as much as possible this flow in the posterior tibial. And when we talk about the inflow of the leg, femoral artery and popliteal artery, I think it's very important to discuss even about the outflow. And finally, pre-dilatation of popliteal artery, and after this, 4 millimeters and 5 millimeter balloon angioplasty. After this, a check. Very bad result. The vessel prep was very, very bad. There was a big dissection, probably a thrombus in the middle of this dissection. So a already previous treated segment without stent, in which I decided to go with a stent. I put a 6 millimeter iEvolution Pro stent, long one to cover P3, P2, and even partially P1. This is my strategy. If you need to stent the popliteal artery for a long segment, it's better to stent completely the popliteal artery compared to go for spot stenting. Spot stenting only if you need to fix a small dissection or a relatively short dissection or recoil. So 5mm stent, the vessel prep was not the best because you can see the stent was not fully open in some places. So for that reason, we post-dilate at 5 and at 6. And this was the result after the post-dilatation. Very fast flow, still some stenosis, residual stenosis in the TP trunk that we managed with the DCB, 4mm DCB, short DCB. And after this 3 minutes dilatation, we achieved this result. Direct flow in peroneal and in posterior tibial, very fast flow. And that's the reason why we need sometimes to improve the distal vessels and the outflow to give more chances to the inflow to stay patent. And this was the flow in the foot. You can see again, direct flow for lateral plantar through the posterior tibial and some precox vein being back after the balloon angioplasty in the foot. But how to check the performance of the stent? Remove the guide wires, because it's the first thing to do to check the performance of a stent in popliteal artery, and do a flexion knee angiography with excellent performance. No stent kink, no stent compression, and so on. So, according to the lesion type, to the crossing way, to the presence or not of calcifications, and to the result of a vessel prep, for sure, there are some cases in which we will need stents in popliteal artery. So I don't think that this is the real question today. It's more important to discuss about which stent to use, because it's clear we will need stent in some cases. So this is a very interesting result of the trial of popliteal stenting with iVolution Pro. We enrolled 107 patients with, 101 patients with 107 stent placed. Those are preliminary results. It's a recent analysis. It was an observational cohort of patients. Most of them enrolled in Latin America, but I was actively enrolling too, so some patients arrived from Italy too, of iVolution Pro stent in popliteal artery. Those are the baseline. You can see it's a normal population with peripheral arterial disease. Most of the patients present with claudication. This is quite atypical compared to European population. In my cases, most of the patients were in CLI. I treat only CLI patients, but you can see some colleagues from Latin America decide even to use stent in popliteal artery for claudication. Wi-Fi class, most of the patients present a high degree of Wi-Fi, so who present CLI present ulcers and infection, and the other ones present a very important claudication. In fact, you can see most of the patients in Rutherford 5 and even in Rutherford 3. So still open discussion if we need to treat claudicants or not, but we know that in this cohort of patients, most of the patients who were claudicants were in Rutherford 3 class. And most of the patients were approached in antegrade fashion. This is just a technical aspect. It's clear that any kind of stent can be deployed antegradely or in a crossover. And this is very interesting. Considering popliteal artery, the lesion length was 120, so 12 centimeters. Is in most of the cases full CTO of popliteal artery, and the stent length as well the stent diameter that were used in the trial. So as clearly could happen and happen even in the case I show, the stent were deployed in most of the cases covering P1 and P2, but in some cases even from the SFA into the popliteal. So no any attention to deploy the stent, or no any problem to deploy the stent in the flexion part of the passage between SFA and POP. Again, interesting to consider how challenged was the population. Most of the patients in task C and D class. So again, talking about long lesions and CTO. The last, but not at least, important information is that most of the patients present moderate calcification. So we are talking about popliteal artery and calcium. And there was a good part, 21% of patients with severe calcification. It's just to consider the performance of a standard nitinol stent in a flexion point with calcium in the arterial wall. Well, other characteristics is not really important, just to underline some cases were performed in subintimal way and the performance was good. And another important inclusion criteria that was to stent from healthy to healthy. I personally believe when we use a stent, we must to take care about to deploy the stent from a healthy segment to a healthy segment. What happened with the follow-up? We saw 71.5% of primary patency at 2 years. It's a very high percentage of primary patency. And 78.1% of freedom from clinically driven TLR at 2 years by Kaplan-Meier analysis. What happened with the patients that needed a TLR? In most of the cases were treated with DCB, but it's important just to show that it was easy to pass inside the stent and to treat it again. And there was a very low percentage of amputations with occluded stents. So it means that talking about the CLI patients, most of the patients underwent to an amputation were not related to a stent performance, but were related to the clinical baseline. So in conclusions, I think today we cannot think about stent-free practice in popliteal region, so it's clear we need stent. The flexion zone do not represent a limitation for stent use. We need a stent with a high patency rate and low rate of TLR and fractures, and the preliminary result of Evolution Pro study are very promising, including long lesions and moderate calcified lesions with very low rate of fractures and with very low TLR, clinically driven TLR at 24 months. Thank you so much.
Okay, so next speaker is Dr. Langhoff. So he's on the web. Oh, hi, Larov.
Hey, Osamo.
Hi, good to see you. So could you start your presentation, please? You're not to stand for popliteal side. Okay, could you start your presentation, please?
Okay, I hope you can see the slides right now. Yeah, just thank you just for having me. And yeah, so I should talk against popliteal stenting in the popliteal artery, which I think is just not so difficult. I think it's a very long and I would say also very old story. And just to make it short, I think the popliteal artery is not made for stenting per se. The question is, so what are we talking about? It is just like in bailout situations, I think everything is allowed. Definitely, I also work with stents in the popliteal artery, but I think as standard of care, I would do a big question mark if this is just the standard of care for the popliteal artery. What are we talking about? That was just the second part of the question. So lesion characteristics of the popliteal disease. In acute ischemic disease, I think mostly it's thrombotic occluded, partially due to an underlying stenotic situation or thromboembolic. In CLI patients, as they are mostly diabetic, it's just predominantly occlusions. They are mostly calcified long CTOs, as Mariano just showed, so complex cases with long lesions. Sometimes they are involving the ostium of below the knee artery vessels, so the entry may be cumbersome and you are just afraid just to lose one of those below the knee arteries, which also makes the point of stenting somewhat difficult. Stenotic lesions, just what we see here at least, they're most often eccentric, calcified, and have a high plaque burden. So these are just not the very easy soft lesions we mostly face. So as said, it's just a very old story. So I think most of you are aware of this, so that this is just a presentation, I think, from 2005, from mouse biomechanical forces in the femoropopliteal arterial segment. Quite interesting, they investigated bare arteries, so that was just a cadaver study for those who are not familiar with this, and they do hip flexion and knee bending, and then they try to calculate and just to measure how long what the artery is doing in terms of shortening, respectively, on the SFA, respectively, in the popliteal artery, and see 70-degree bending of the hip and 20-degree bending of the knee resulted in 9% popliteal shortening, respectively 90 to 90-degree bending resulted in 14% of shortening. And you see this here just only for the popliteal artery, even if it's stented with a flexible stent. So that was just in 2005, just like a first or second generation stents, but anyhow flexible ones. Still, there was a shortening of these stents, which, if you just talk about 10%, we say just a mean, if you just have a 10 centimeter long stent, is going to shorten out at least to 1 centimeter. That was the artery wanted to do. So this will react in a lot of biomechanical forces to the stent. What Mariano already pointed out, so if you are forced to stent, definitely you should aim for a single stent, not for several stents, because in these parts where the stents are overlapping, they're shortening less, and you're doing much more harm to the artery compared to a single stent situation. So this stent will not shorten anyhow in the overlapping zone. So the aim of this cadaver study was to find the ideal stent, and what they said was just it should be the best stent should be a series of independent flexible rings, not interconnected, providing radial support without impeding the altering of physiological axial compression and bending of the artery. So this is maybe something of a newer generation stent, respectively spot stenting, respectively something where the wires are moving independent, like with the Supera stent. So this is one of the stents which may work there. Yeah, so the special anatomy. So during overextension of the knee, we have an elongation, we have shortening, and also kinking is possible to more than 120 degrees. During exercise, 88% of the adults show complete compression of the popliteal artery. So this is just an artery which is just quite under stress. So compensatory behavior of the popliteal artery, I think that's quite well known. So if you just stent and stiffen out the part, so there will be a compensation of the artery, which will be mostly at the already mentioned hinge, respectively flex point in the superficial femoral artery. So that's what you can see here in this bare popliteal artery. When you bend it, there is a shortening here of 9, respectively 40%. So they measured this with the collaterals. And if you just have here marker stents, you can also measure quite easily what's going to happen if you just stent out the P1 and P2 segments. So there will be a shortening and also compensatory reaction of the artery itself. So to my concern, I would say vessel preparation in combination with drug-coated balloon and to avoid stenting is the preferred approach. Because of what? Because you do not lose any future options. So it is something you can do redo cases with DCBs and also with atherectomy or plug modification like you do with IVL. And still you can go for stenting in the future if needed in a bailout situation. Just to show you some representative cases, distal popliteal occlusion in a Rutherford 4 patient here. You see there is an occlusion of the P3 segment here. There are collaterals. They are filling below the knee arteries. So it was just like a situation here with an ABI of 0.5. Lesion length was close to 10 centimeters, totally occluded. There was no calcium here. So to stent this is definitely an option. So probably just to recanalize is not so difficult, but yeah, you may lose the anterior offtake or the tibioperoneal trunk. So where to enter is not so easy. So what we did here, so we went for atherectomy here. You see just after the first cut with an atherectomy by second cut. And then if we do an LO projection, you see that we just missed a part here distally. So another cut, then using a DCB. That was the final situation here without stenting. ABA returned to almost normal. and patency was good in this patient. Second case, different situation, so totally calcified, and this would be just definitely also a case you can solve with stenting or with IVL. So what we did here, we went with a HOG1 device here, with spider protection system very distally. After 3 to 4 passes, it looks like this here. Then we added a DCB 6x80 luminor balloon here, 3 minutes of inflation at 8 atmospheres. That was before, that was afterwards. So a quite nice result, which just leaves any option just for the future still available for the patient, even you do not have any, you still have chances for a bypass, P3 bypass here. Stenting is something we also do, but that's just like the distal SFA here. Vessel preparation sometimes is quite cumbersome, and that's also vessel preparation you may need to really have a good results with your stents, and sometimes you spend more money for vessel preparation compared to here. So we used a scoring balloon to crack the calcium here, then we just used an additional larger balloon to prep here for a supera stent we just intended to place here due to this huge amount of calcium. And that was the final result. But what you can see here, still the disease is still present. So there is a lot of calcium. The stent is patent, it's open, but we just left a lot of calcium in this arterial wall still. So what's about data? I was not aware of the data Mariano presented because it's just not published. If you look for published data, it's mostly single center, respectively retrospective data, and also not compared. So there was one trial, not published, but a Spanish trial looking for atherectomy compared to stenting with PTA and atherectomy in combination with DCB. But there was no publication available right now, but they finished 2 years ago the randomization. The ETAP was just the live stent, especially investigated in the popliteal. So it is so considered no stent zone, and there was prospectively comparative control trial versus PTA. So stenting versus PTA in the ETAP trial, you see here primary patency was in favor of the stented group here compared to PTA, but we know that PTA alone definitely is bad for the SFA and also bad for the popliteal arteries. So the comparator here definitely, in terms of the historic data that was just published several years ago, was not the right choice today. I would say definitely we need different comparing data like atherectomy plus DCB compared to a new generation stent. The hardest endpoint is major amputation, respectively death. So these were primarily claudicants, so there was no change in minor, respectively major amputation for either group. TLR rates was definitely in favor of the stented group here compared to the PTA group, but I think the comparator still was not nicely chosen. Just to finalize here was just like a sort of a debatable algorithm. I think vessel preparation according to the lesion, which just includes also IVL, includes scoring balloon technology, respectively directional atherectomy. Then go for a DCB for 3 minutes. If you just have a PTA failure, then you may consider of a modern generation stent, respectively a VMI. And then you just finished with a combination therapy of DCB, respectively the standard area, which I think is good. If you just have no PTA failure, so mission is accomplished. If you see lesions which are very, very calcified with a high plaque burden, extended calcium, I would just suggest to go for debulking and plaque modification first, and then maybe consider VMI if you do not succeed with these techniques. Otherwise, go for DCB, and then mission is accomplished. Thank you.
Just before the debate, we can ask perhaps to the audience if they are in favor or not of about popliteal stenting. So, if you are in favor of popliteal stenting, raise your magenta card. And the blue one, for the no stenting zone. Both together.
I cannot
It's
see it
difficult.
as a translator.
Yeah, it's very difficult.
50-50. So guys, you are on the same line. So go ahead for the debate. Question from the audience, and Ralph and Mariano, you answer. Question, Guy? I know it's time for sleeping, but no, it's time for answer, for question. Yes?
One question there.
Hi, Ralph. This is Jacob Novotny from Israel. We have some experience with. I'm a vascular surgeon. We have some experience with cross-knee stenting, and for positive and for negatives, specifically when somebody closes off some distal options. So I'm very much in favor of using all of our technology to prevent stents in the popliteal artery and the distal runoff via the new technologies such as atherectomy and DCBs. Question for you, since we had a debate beforehand about covered stent and non-covered stents, how do you feel about putting covered stents, going even further, putting covered stents in the popliteal artery such as Viaban?
Yeah, so we just have some experience with popliteal aneurysms. So what I think is that the Viaban is a little bit too flexible. So we just had several situations where we just had a kink in the Viaban. We reinforced the Viaban with superas for sometimes. And what we do right now, even in popliteal aneurysms, we try, if ever possible, in terms of sizing, we use double layer technique with superas. So my experience with Viaban is limited. There are collaterals you may harm if you do not have the right stented length. So I'm always afraid of these acute ischemic disease. But to exclude the disease always is nice by either atherectomy, respectively, something like a Viaban. We do Viaban for instant reocclusion, several ones, just to exclude the disease and just to form a new bed.
Yeah, more or less, I agree with Ralph. Cover stent, the only indication I can see in popliteal arteries to treat popliteal aneurysm or as a bailout after bleeding, after a big damage of a popliteal artery. Other ways, there is no specific indication from my side to use a cover stent in popliteal artery.
So Mariana, so I have a question about so how percentage of popliteal stenting in a clinical setting? How percentage? You proceed a percentage? Less than 10 or less than 5? You are general practice for popliteal treatment?
Honestly speaking, my step-by-step treating a popliteal CTO, here was a discussion between cons and pros. So I defend my position, but I think that the exposition was very similar between Ralph and me. We have been saying more or less the same things. So it's important to cross, and the way you cross could define a bit your treatment. Ralph talked about atherectomy. If you are subintimal, I don't believe atherectomy can be used. So there are some things that allow me to decide I'm going to choose a stent. The time I realize I need a stent, it's important to decide which stent. I don't believe, and I'm a very big defender of Supera stent, but I don't believe Supera is the only stent you can use in popliteal artery. For example, the case I show with a standard nitrogen stent with Evolution Pro, excellent performance, and all the result in this trial, only 2 stent fractures. And what Ralph showed us about the dynamic during the movement of popliteal artery is the same for every one of us. So it's clear that some standard nitrogen stent perform pretty well, and we can still think to use this stent in popliteal artery. The most important thing to decide which stent in my mind is the presence of calcium or not. So in subintimal way, in calcified arteries, really believe we need stent, and if the risk of stent fracture is so high because you went around the arterial wall, in those cases I like to use Supera. For all the other cases, I think Evolution Pro can perform pretty well.
But I think just maybe to emphasize, I think Supera is just a good stent for popliteal arteries, but it's not the only one. I totally agree. I think that also the strut thickness is something you have to consider, because you're decreasing the inner lumen, because there will be a neo-intimal layer there. And if you have small arteries, probably Supera is just not the first choice.
Good.
So a question for both of you. I've seen Ralph's presentation very careful. So the actual connections are seemingly a little bit the problem here. So is the technology that we all know on one side, the TAC device without the actual connections, on the other side, the multi-lock? I know that Ralph has some experience with this. So these little short tacking devices, is this then more appropriate in the popliteal artery, or how do I need to see this?
Good question. So I think the data for so that was not really systematically investigated in the popliteal segment. I think it's just not the best way. And I think also that if you just see the tech device, I don't see it on the market any longer. So in Germany, I think the penetration is almost zero. It is just not the best choice. I think it is, if you just have really severe dissections, I think, well, personally, what we do right now is that we also go for stenting as a bailout situation, that if we just judge this to be flow limiting, I think we have to seal it and we have to use a scaffold there. And then we would go for full lesion coverage today by a flexible stent. I think the other way is to really carefully recanalize, and that's also like a bilateral approach then, to intentionally go even maybe retrograde there and then try to see that you're not running into so severe dissections. And there are a lot of cases we are able to finish with a combination therapy of atherectomy, respectively, in combination with a DCB or DCB-only strategy. So I would not vote for tech, and I would not vote for the multi-lock stent in the popliteal.
I personally agree with Ralph. TAC, I don't have experience, but seems to be not a stent, just something to fix a dissection. When you have a calcium, TAC probably is not performing in any way. And I remember some cases with a multi-lock in which the stents remain patent and you have restenosis or reocclusion in between. So it seems that spot stenting is not the best option for popliteal artery.
I have a question for both of you. You don't speak about P1, P2, P3 about popliteal. What is the reason? You don't care of this different part, or what do you think?
From my side, I care. Honestly speaking, yes. The worst place for me, or the more challenging, more demanding to take a decision is P3, because you have the ostium of tibial arteries. So when I said from healthy to healthy, this is in my mind a very important and stressful point. If you have occluded the ostium of tibial arteries, it's going to change my decision, and sometimes decide to try to avoid stent, or sometimes extend the stent till the TP trunk, as I showed last week during Click. But P1 and P2, from my side,
you don't care?
No, I don't care, no.
Ralph?
Yeah, I think that in terms of stenting, P1 and P2 are quite challenging situations. So I'm always happy to stay away for stenting in P1, P2. And it's a very easy way to do atherectomy there. If it's P3, it really is an intention where we go primarily retrograde or bilateral, so that we are not hitting the ostium of either below the knee artery. But I think that P3, if you can stay away from the ostium, it's the more easy way to stent compared to P1 and P2.
Okay, great discussion. So we should vote?
Yes.
And after great discussion, so I will contact you about if you want to stent is pro, please hand the red one. And if you do not want to stand for popliteal, blue. Please hand that. Please.
Raise your card.
Stand for red and not stand for blue.
Magenta for standing. So we should say that perhaps the magenta guys are sleeping, but blue,
We're not standing.
Blue wing.
blue win, definitely.
Blue win. The love win. Congratulations, love.
No, okay. It's
Thank
just
you,
not my
Ralph.
thing.
Thank
I
you,
think that's just as said. So we also use stents, and your question, Osamu, definitely I use more than 10% stents in my popliteal cases because there are some bailout situations
But-
where we just
But I think the standard result is amazing. From the 1 year's primary parents, that over
Absolutely.
the 80%, and compared with the life stent, the second generation stent.
Yeah.
Anyway, the stent is one innovation for popliteal treatment. Thank you very
Absolutely.
much.
Thank
Yeah.
you. We have to move to the next session, and it will be about long lesion for FemPop segment. Mario, you can. Thank you so much.
All right, thank you.
So I have the pleasure to call the first speaker, Lieven Manne, about to talk about this complex long lesion. And you start by a case, I guess.
Yeah, absolutely. So it's always a pleasure to have a nice discussion and see what the audience thinks. But before I start with the case, I would like to make a small statement. I'm very happy in Belgium, but from a health economical point, I'm not so happy. So specifically when we talk about the popliteal area, we don't have endarterectomy. And we have in Aalst, where I work, a huge calcium burden. So yeah, in a lot of situations, I'm just sitting there watching my prepping and everything is recoiling. So I'm sure there's many among us here that are in the same situation. And we need something. We need something. Or money from the reimbursement, or we need stents. So this said, the popliteal or the FemPop lesion, well, I'm always thinking about these nice roads in the mountains where it's great to go with a car or by motorbike, and then we have these curves. Well, they make me think, of course, of the popliteal artery. And I found a case that I would like to share with you. It was a nice gentleman that came in with a Rutherford 5, also on the left side. He first got an ultrasound, which showed a diseased FemPop segment with an occlusion, a popliteal with quite some calcium burden. So there was a quite fast decision that we took him to the lab. And as we always do, we try to be on the spot. So we made an antegrade axis, and we made a first line of angios. And as you can see, there is some disease in the proximal FemPop area, calcium load, and then an occlusion of the popliteal, extending with then some nice re-injection at the distal popliteal and the trifurcation. Runoff, I'll show you later on. There is a single runoff in a diseased but acceptable posterior tibial artery. Okay, I was like, well, not too long lesion, diffusely diseased segment, okay, but should be not that much of a problem. Okay, some challenges maybe, the calcium load, and if I took an angio a little bit closer, well, yeah, I was confronted with quite a lot of side branches sitting there because of this chronic CTO. So I gently probed with my first 035 Terumo wire, but was not successfully, so I quite fast shifted to an 018 platform, and I tried a little bit. Yeah, go ahead.
Perhaps because we have also mixed interventionalists, we have vascular surgeon, cardiologist, and angiologist.
Yeah.
Perhaps open surgery is still an option for these patients.
Well, I didn't show the runoff. I'll show you later. It is an option, but okay. We can
ask
we
perhaps
can vote.
to the audience.
Yeah. Okay.
So
Who would go for endovascular first? The magenta side. Yeah.
endovascular.
I think
For the blue ones, they can eat tonight. Huh? If you have, you put the blue one, you can eat tonight. There is no problem for that.
okay, I think, to be honest, it was not such a long occlusion. Okay, some calcium, I think everybody here, that should work. But nevertheless, I was a little bit frustrated. I started and I could not get into the through lumen. So although I tried with spinning and drilling and then augmenting a little bit the support, so I tried a bit harder, and you see the results after like 5, 10, 15 minutes trying. I started a little bit worrying about the side branches, and I still didn't get in. Okay, good, yeah, I needed to do something. So I said, okay, let's go back to the subintimal space then. I took back my, my 035 wire to have a little bit more support. I brought my balloon close and I pushed. It was very hard, extremely tough. I didn't really like the behavior of the wire. And then suddenly I really said, okay, this is not going good. Should I do that? Maybe, oh, damn. Okay, little problem. Okay, yeah, now what? It's definitely clear, big loop. This is, yeah, eminent rupture or at least a big subintimal space, not what I want. Okay, yeah, well, they've always told me if you fail the first time, maybe you can redirect and try a second time. So that's what I did. I took my catheter and I tried a little bit from a different angle. I took some projections and I tried if I could pass this subintimal pathway. So I tried a bit, it took me some time to get in, but in the end, okay, I got a little bit further, but I was not so happy. I was not happy at all in the end, because when I turned, I saw that I was more in the subcutaneous tissue than I was near the vessel, so probably I just entered in a different way again in that rupture, got really stuck. In our lab, the patient was under general anesthesia, but I'm sure he must have complained when he was awake. So, eminent or already rupture, descending hematoma, single runoff, yeah, what to do? I was like, okay, I had planned this for an easy case, not for disasters like this. Okay, maybe I was a little bit too frustrated with my big wire, but okay, it happened. And sometimes it happens. So what to do? Okay, let's make a poll. Who's continuing endovascular or who is going for surgery? So magenta is endovascular. Okay, I see majority still courage. Oh no, I see already some people that are convinced. Okay, so well, bleeding is definitely going because I'm like two centimeters away from the vessel. So bypass, retrograde attempt later, so stop, do some compression bandages and then maybe later, or just try now. This was the runoff. So on the CT scan, quite acceptable posterior tibial, no anterior remnant of a perineal. Well, I said, okay, let's see what I can do if I can do it in a reasonable time frame.
It is a CLI patient, huh?
CLI patient, yeah. So a reasonable time frame. I said, okay, let's try. My favorite puncture site for retrograde punctures, if it's an area on the fempop, is the window between the tibia and the fibula. Yeah, I think it's quite easy if you rotate the leg a little bit, if you flex your fluoroscopy machine with a micropuncture and an 018 wire to puncture the anterior surface of the popliteal artery or the tibioperoneal trunk. And I was lucky, because when I did a roadmap, well, there were still the collaterals filling, and I had, yeah, quite nice filling of that distal popliteal. So I could, yeah, very easily puncture. If that was not successful, I would definitely have punctured the posterior tibial on the lower base near the level of the ankle. Okay, but still challenges, because the calcium was still there, but my biggest problem, of course, was that rupture. Potentially, that subintimal space and that whole area was one mess. So, yeah, I will have to be careful. So very gently I went up with the wire, but already quite fast I said, okay, I need a little bit more support, a little bit more steerability, so I took a catheter, I went in, very easily first part, because it was open. And then, of course, the rendezvous area, I thought, oh, this is going well. No resistance at all. I just pushed with wire and catheter. I thought, okay. But I was not on the right spot. So through probably the ruptured subintimal space, it got in another subintimal space, and we were side by side. I tried a bit, gone back, turned, not successful. So rendezvous, but rendezvous is not always so obvious as in real life. Okay, next step. I think most of us know that if the membrane is there and you can weaken the membrane between the subintimal space and the true lumen, then there's a big chance that you can open up. So that's what I did. So I took a balloon, I came down, and I started the pre-dilatation of the SFA already, and I started the PTA of this, one back. And I started performing a PTA of this rendezvous area, but paying close attention, of course not going too low. I was not opening up the ruptured area and feeding the ruptured area with bleeding from proximal, so gentle opening. And then, of course, when there was room enough, once the PTA opened up the space and ruptured potentially the membrane, well, I was able quite easily to find the true lumen again from below. Okay, luckily I had my through and through wire still there, so I had a good support. Nevertheless, 018 platform, low resistance platform, and with some pushing, I was quite easy to bring the balloon down through the ruptured area, and I opted for a gentle dilatation, hoping that the vessel was not completely torn or that it was really a focal lesion. If a focal tear, then hopefully there was enough vessel that was structural to potentially hold its integrity. So over the wire, building up for 5 millimeter balloons. And in the end, this was the first angio after 5 millimeters. Yeah, what we could expect, of course, calcium load, maybe some fibrosis. So there was the recoil. I thought, okay, I need to make some space if I want to take away the resistance, whether I want to do any kind of strategy for DCB or stenting. So I went up with a 6 millimeter balloon, took it a little bit longer, but the image is more or less the same. So the cumbersome area did not really open up. Yeah, the flow was not that wonderful, and we got some ugly dissections more in the proximal part, and in the proximal area also quite an unacceptable AV fistula. So to make a long story short, I don't have any other options than to overcome this mechanical problem with a mechanical solution. And since we don't have any other option than stenting in Belgium, that was the pathway that I had to choose. So I brought down over this wire the iVolution Pro. It was quite a long lesion, so I wanted to go from more or less healthy part to an acceptable part proximal. That's why I put a 200 millimeter stent. And I found that proximal was a little bit too short, so I added an 80 millimeter stent. Of course, the proximal part of the SFA was prepped and finally treated with a DCB. So in the end, ugly passage, recovery of the passage, but the integrity was acceptable. So after stenting, and after treating of the proximal SFA with DCB, I was quite happy to find a brisk flow in the proximal segment. I did not see any extravasation. So although I had a terrible image during the pathway, well, the stent was capable of keeping the right track, and the outflow to the posterior tibial was restored. For that moment, I relaxed and stopped, and in a later phase, we then tackled the below-the-knee vessels. So, remarks, questions, different things.
We go for the next speaker.
Okay, we go next speaker. Okay.
Even, take a seat.
Okay. So next speaker is Dr. Kundeles, my friend. The title of his presentation, the 1 + 1 = 3. Unique title, introducing the tinting technique.
Can we ask a quick question before or afterwards?
Very quick. We make the discussion after the last talk. Both discussion together.
Thank you. Yes, indeed. And I'm also going to start with a case, a much easier case than Lieven's case. It's the case of Harry, a typical Belgian gentleman. Within the history, a bypass on the right side, PCI in 2021, cerebrovascular accident, so some cardiovascular, neurological, coronary problems, and unfortunately also very typical Belgium, still smoking. So also, although you don't see this on this picture, a body mass index of 32, the upper half is quite good, but the lower half, distal half, is much more fatty due to beer and chocolates. Hypercholesterolemia, arterial hypertension. And so he was presenting with claudication, Rutherford 3, during or since 6 months. We did a duplex ultrasound. There was a triphasic signal in the groin, and there was a monophasic signal at the level of the popliteal and the distal vessels. So I'm going to show you immediately the images. So you see an almost, I'm going to do this here. It seems easier, although, yeah. So it seems like a flush occlusion of the SFA running all the way down up to Hunter's Canal, and then at the distal SFA, P1, a re-injection, and a very good outflow in below the knee. So are there some decent or indecent proposals to treat this lesion? First question, do we need to treat this lesion? Yes, raise your card, whatever the color is. So a lot of lazy people in the audience, I see. So we decided anyway to treat, but I totally agree. Supervised walking exercises, stop smoking, probably is a better proposal. But we know the Belgian patient is very uncompliant, so we decided to treat. We decided to do a contralateral puncture, 6 French, 45 centimeter crossover sheet. And then I try with a Berenstein and an O35 Terimo glide wire to look for the ostium of the SFA. But as you can see, or I'm prolapsing with the catheter into the deep femoral artery, or my wire is curling up all the way to the proximal area. So struggling a little bit with this, we had the great idea to change from a curved Terimo glide wire to a straight one, and to really poke, to puncture the ostium of the SFA. And you see a few millimeters there are entering into this occlusion. And then, of course, you give some support with your Berenstein catheter, and you advance your straight wire into the SFA, as you can notice over there. But after a couple of 7, 8 centimeter, the wire blocked, was stuck, and so I try to follow with the catheter. And seemingly this seems to work for a couple of centimeters, 4 centimeters in total, and then everything was blocked. So how to continue in this situation? Well, we go back again to our Terimo glide wire curved in order to switch the strategy from an intraluminal to a subintimal recanalization. And this with a loop, and I don't need to explain you this kind of Bolia technique where it is quite easy to go with the loop all the way down and playing a little bit with the length of the loop, soft loop, stiff loop, to cut as a knife through and through the subintimal space. It was not so calcified as Lieven's case, by the way, as you can see. And so but step by step, as you can notice here, the subintimal recanalization was moving on. And so there is the point of re-entry, as you can see. So with the spinning loop technique, I keep the loop quite short, for quite soft atraumatic loop, but by spinning it with a torquer device, it was quite easy to reinforce the re-entry. Of course, we've seen it in Lieben's case, it's not always so easy. Here you see that we are nicely intraluminally. There are other techniques, as perfectly demonstrated. You can do an angioplasty, try to create a tear in between a real and false lumen. You can use a real re-entry catheter or device. We in Belgium, we are using a poor man's re-entry catheter, means like a universal flush catheter that we are cutting in a sharp way and trying in this way to puncture from the false lumen to the real lumen. You can use a retrograde axis, you can use bilateral, bidirectional axis, and the card and reversed card technique in order to make your re-entry. Here, this was all not, was no need for, and we started immediately with the vessel prep. We just are performing angioplasty with an Oceanus balloon, starting with 4, gentle, calm, not as aggressive as Lieven did. And so we are ending up with 6. My recommendation there is to use high-performance balloons. So not all the balloons are the same, by the way. If you look very careful to all the different devices on the market, you're going to notice very important differences. You can use specialty balloons if you are rich, if you are even richer intravascular lithotripsy. No atherectomy, because we are in the subintimal space. And this is the result of my vessel prep. So, question, a lot of questions. There is no time for voting, but so who is happy with this result? Probably just raise your cards. Are there some people happy with this result, final result? One happiness. Okay, so you're gonna stop here. But looks good, okay. Yeah, DCB is an option, DES is an option, bare metal stent, combination of DCB and bare metal stent. You can use covered stents. I know that there are some Viabahn lovers in the audience. You can do thromboatherectomy, I don't know why, but it's an option. And of course, last but not least, if you are not happy as a vascular surgeon with this result, you can say, oh, stop this, let's go for a nice above-the-knee bypass. In our service, we have a kind of an algorithm that is based on passing, prepping, and treating. So the way I'm going to treat is influenced by the way I prepped, and the way I prep is influenced by the way I pass the lesion. So here in this case, it was, I call it like a regular subintimal passage. So I did my preparation with simple plain old balloon angioplasty. And then finally, I look if it's not extremely calcified, if it was a quite straightforward passing, like in this case. Then I look, is it an angioplasty responder or non-responder? That's, of course, also a subjective interpretation. We don't have intravascular imaging available. So I was a little bit like you mentioning, it is a quite good angioplasty responder, with some exception probably in the proximal area, but the remaining part looked quite well. So why not continuing with DCB? And so I started to dilate everything with a Luminor 6100. Important here is to avoid, especially in these long lesions, to avoid geographical misses. So that's the reason that we are making a roadmap of the inflated balloon, and then our next balloon, it's easy to position it with a small overlap in order to definitely avoid all kind of geographical misses. You need to choose the right drug-coated balloon. There is no class effect. Every drug-coated balloon needs to be proven on its data. You need to size in a correct way, gradual inflation time, prolonged inflation during 3 minutes, and then a full deflation before you are retrieving the balloon. I think very important options to be successful with DCB therapy. So this is the result, post-DCB. Some more in detail. Dissection, thrombus, a flap, recoil. Happy? More people are already happy now? The paclitaxel is inside, so everybody happy? No? Unfortunately not. So what to do? Another angioplasty. We did the prepping. We did 3 minutes inflation time with the DCB. Do we need to do a bailout with a bare metal stent? Do we need to use a drug-eluting stent, a covered stent? Or again, there are some persistent people who absolutely want to do atrial thrombectomy. Open question. I decided anyway to do a bailout stenting, provisional stenting in the proximal part and just landing at the ostium, because it seemed for me in different projections a dissection starting at the ostium and in a spiral way going at least 10 centimeters down. So we used an iVolution Pro 6150, and this is the result post-scaffolding. So look at the flow. That's the outflow up to the below the knee vessels. And that's the way I ended, by the way, proximally with the stent. So some people are always afraid of flaring a little bit in the proximal and even in the distal common femoral. They say, oh, you're going to lose your profunda. Take care, Dr. De Loze. You see, it's not the case. I think this is the right way, flaring open with one proximal stent structuring at the proximal side. So who is happy now? At least a few people already. Thank you very much for this. So why I did this treatment, and that's the last thing that I want to point out, because I'm a strong believer in this particular combination, DCB Luminor with the iVolution as a stent. Why? Because we have the Tintin data, and this is a study, the combination of these two devices in task C and D lesions, with all these in and exclusion criteria. And I would like just to give you an overview of our results at 48 months. And this year we are working on the 60 months, 5-year results. So first thing you need to notice is that when you are doing, and a lot of people are saying, oh, we need longer follow-up for trials. I totally agree, but you see that there is, especially in this kind of trials, a high dropout in terms of deaths, in terms of missed visits, in terms of loss of follow-up, and so on. So this was one thing in these 100 patients that we were realizing. Very sick people. So 30% were CLI patients, 70% claudicants, but with mean lesion length of 24 centimeter. And so here you see the survival rate. The typical peripheral arterial diseased patient is a very sick patient, especially with task D lesions. So we notice a survival rate of 61% at 4 years. And especially worse in the CLI group, where there was only 43% alive, 4 out of 10 was alive after 4 years. Here you can say, Katsanos is not in the room, you can say, it's due to your paclitaxel. Of course not. Here are all the reasons, and nothing is related to the paclitaxel. So freedom from major adverse events, death, clinical driven TLR, and amputation in 44.6% of the cases, mainly dictated, as you can see, by the deaths, 36, 19 clinical driven TLRs, and 1 major amputation in the CLI group. This is probably the most important slide. So 1 out of 4 was retreated, had a TLR at 4 years. So it means that 3 out of 4 with this combination, Luminor and iVolution stent, still didn't have, after 4 years with 24 centimeter mean length lesion, no re-intervention. Also from a clinical perspective, as you can see, the persistent data in Rutherford shift and ABI improvement are there at 4 years. And if we are benchmarking, as the final slide, with DES studies, with DCB studies, especially in this long lesion cohort, you see in red that the Tintin results are at 48 months quite outstanding. So leaving nothing behind remains, unfortunately, a dream in real-life lesions. Scaffolding with a bare metal stent alone is insufficient in complex lesions, and especially in terms of durability. The Tintin trial with the combination Luminor and iVolution shows at 48 months in lesion of 24 centimeter only a TLR of 25%. Unfortunately, poor prognosis of our PAD patients with these kind of lesions, a survival of 61% at 4 years. And if we are benchmarking this combination, DCB plus BMS, with other efficient drug-eluting and scaffolding trials, we see that they are at least as durable. I thank you for your attention. Sorry.
So we can start for technical and strategic question about long femoropopliteal lesion. We can start by first question. We have a yeah. We start by you.
Thank you both for the great presentation. My name is Saad Ben Aid. I'm one of the vascular surgeons in Saudi Arabia. Just for the first topic, when you access the distal popliteal, at the end, do you use a closure device or pressure just you as well in that area?
I think the most important part in this axis is the axis itself. So you need to do a delicate puncture with a micro needle, an 018 wire, and 018 catheter or device. If you are very gentle and you pick a spot not right in the calcium but just above or below, then there's hardly a problem. If and sometimes I do a little angio in between. So if I do my vessel prep, I've done that, and I do a little angio and I see a small blush, then I go with my balloon and I do a gentle inner dilatation, low pressure, and then I haven't had any problems yet so far. But the puncture technique, very careful, is for me the most delicate, and I never use a sheath. So always direct with microcatheter.
I think personally also my experience, sheethless here is the, I see unfortunately in congresses and even in live cases, people with 6, 7 French, they're going retrograde in the tibial vessels. I have also my doubt on this. I think if you can use it just a wire support catheter, low profile 018 based, without a sheet, without big devices, just to use as your retrograde recanalization tool, and then afterwards you treat from antegrade, you do your definitive treatment and vessel prep. That's the safest way to go.
Gilles? No. Gilles Goyot. Microphone, please.
And meanwhile, there is a question.
Hello?
Yeah, first, and then
Yes.
Gilles Goyot. Go.
One question to Dr. Deleuze. Do you believe that we have always to put a stent in the orifice of the superficial femoral artery in case of flash occlusion?
No, I don't think so. Like in this particular case, but in all the cases, I just look which segments are angioplasty responders and which are none. So it's not depending on the location. Say, yeah, I always place proximally or always distally. I look where it is needed. Having said that, I notice, like in this kind of recanalizations, that most of the time your entry and re-entry zone are zones that are more sensitive for scaffolding.
Also, and you point out during the presentation, there is a sensitive zone. It's the origin of SFA.
Yes.
Because in some occasion we hesitate to implant a stent because we are close to the femoral bifurcation. But it could happen that you occlude all the segment because you don't treat properly this zone. What do you think?
I totally agree. I'm always mentioning this also to my fellows. The surgical adagio of inflow, also for a bypass, if you want to make a successful bypass, inflow is key. So if you do all this work, spend all the money on recanalizing this long SFA, and you leave a lesion or a flow-limiting dissection or recoil or whatever proximally, it's all nothing, invaluable.
Gilles.
It was just a short comment on the same topic that I share with you and especially with Koen. But in your particular case, Koen, don't you think you have to perhaps cover the entire ostium of the profunda? Because sometimes when you just deliver the stent at the mid part of the profunda, for long-term result, sometimes you have endothelialization of the stent at the ostium of the profunda, and you have a stenosis due to the not entirely covering of the ostium of the profunda. And sometimes I prefer to put the stent a bit more proximal into the common femoral artery. Don't you observe it?
I personally don't have this experience, especially in this case. It was a big profunda, so there was no irritation or let's say interference with just this proximal ring of the stent. In general, it is really. I try not to touch the profunda if feasible. Of course, if there is pathology, we also try to treat it. But if it's looking like a healthy profunda, we don't touch it.
I think more and more, even from the experience of treating the common femoral, now we're more and more going from common femoral already into the SFA. Even if you overstent the profunda, even if it's diseased and you leave it like that, very, very seldom it closes.
That's what I meant. I would have put the stent
yeah,
more
but here it was
proximal
healthy.
in the common.
Yeah.
It's healthy.
And to cover the origin
Yeah,
of the...
to cover the osteum.
Yeah, but then sometimes the sizing mismatch is a risk, because the common femoral.
I'm still a vascular surgeon, so the
Still
deep
vascular
femoral
surgeon.
artery remains the holy artery.
Perhaps we can benefit from experience from Japan also. In Japan, how do you deal with this long lesion? Scaffold, no scaffold, eluting device, not eluting devices? What is the current treatment for long fempop lesion in Japan?
I think it's up to the combination of the popliteal artery. It's an isolated SFA region. We prefer the DCB alone because in Japan, the concomitant use of the stent under the DCB therapy is not reimbursed. We decide to perform the DCB alone. We finish on the DCB. But if the angioplasty failed, we decide to implant a drug-eluting stent of full metal jacket like a previous person.
But like in my case, Osama, I started with the very positive vibes of having a good angioplasty responder. In Japan, you continue with DCB, but then at the end, you have still this problem.
Maybe DCB, prolonged vessel dilatation with a larger DCB angioplasty for proximal side. But if the residual stenosis or dissection, we put a stent conditionally, maybe the DS.
Yeah, okay.
A question for Koen. When you use this association combination between the DCB and the BMS for complex lesions, long complex lesions, you make it like in this case DCB first and then stenting, or in some cases you will scaffold and then you will post-dilate it with ADCB?
Yeah, very good question. And I assume you did it this way? You stented first and then post-dilated with the Luminar?
No, I did first.
The Luminar, okay. Personally, I'm more in favor of, so not related to the Tintin results, but there it was very clear in the protocol, DCB first and then stenting. I also do it in this way in my daily clinical practice. Having said that, you know that we have like the DBAS trial with biotronic materials, Paseo-Lux combined with the biotronic stent, the pulsar stent, and there in the DBAS trial it was vice versa. So first stenting and then post-dilating with the DCB, also with outstanding results. But we need to mention here that the pulsar stent has, of course, a very, very, very thin strut profile. So the amount of paclitaxel that is spoiled on the struts and not going into the vessel wall is minimal. I'm not sure that if with the combination Luminar and Evolution, that this is the same, because the struts, it's an O35 system, logically, are a little bit thicker, and you're going to lose a little bit more of your paclitaxel effect by post-dilating with the DCB balloon.
Okay, we have another question, and the final question.
Thank you. I'm a vascular surgeon. I want to ask, because you both asked and mentioned about converting into open surgery, what was the patency rate of these two cases? I mean, at 1 month, 2 months, did the reconstruction still work in both cases, or?
So the last point was in terms of follow-up or in terms of medication?
Yes, in terms of follow-up.
Follow-up. Yeah. So well, first of all, to be clear, I think both cases are also completely open for open surgery. In my case, for instance, and I also think in Lieven's case, surgery is still possible.
So we start at least, and the Belgian patient is asking for this, we are starting with a minimal invasive solution first, with the lowest mortality and morbidity figures, but always as good vascular surgeons with plan B, C, and D in our head. And so we are not standing all the way over landing zones for bypass surgery. So in my case, FP1 bypass was still perfectly feasible in terms of follow-up, 1, 6, and 12 months.
Yeah, for me it was the CLI patient, so this one is coming every 10 days or every 12 days for his wound care checkup. But after that, indeed, it's more a clinical follow-up, because the CLI patients, we're not going to intervene again if it's occluding. It's wound care, and then we wait and see. So then, again, after 6 months and 12 months, but without the need for intervention.
Okay, so thank you. I thank you for the speaker, for the presentation. Thank you, my co-moderator. And we move to the next session. I call Banas. Ralph is not here. Could you moderate the next session with Bar? Ralph is not here. Could you moderate the next session with Bar?
C'est quand? C'est pendant 15 minutes ou maintenant? Il n'y a pas de coffee break.
Okay. The next.
Yeah. Voilà, Fabrizio. Okay. Parfait. The new moderator. Yeah. Good. Success.
Good. So we move to the next session. Hot topic. This will be very interesting because we will discuss 4 topics that for sure are very interesting and challenging with different opinion. I'm very proud to be one of the moderators of this session together with Dr. Nasser, that is going to introduce our first speaker.
Yes, thank you. So it's a pleasure for me to introduce my mentor and friend, Professor Gwafik, to speak about the radial axis, why and what do I have to do. Please, Jan.
Thank you. Thank you so much. First question for you guys. We use in a routine practice radial access to treat peripheral arterial disease. So red, I use radial access. Blue, I don't use. Okay. Okay. 20-80. 20 in favor of radial, for radial and 80. Okay. So, again, the treatment, the algorithm is not just the treatment. In fact, when I speak about algorithm, it's first to speak about the approach, then to define the crossing technique, third, to define the vessel preparation technique, and finally, to give the treatment. So today, we're going to focus about the approach and mostly about the radial approach. If you look about the literature, we have more and more data about the transradial approach. First study, LODA in 2021, transfemoral approach access is associated with increased risk of vascular complication and mortality in comparison to transradial approach. Secondly, transradial approach compared to the transfemoral approach may reduce access site complication and serious adverse events, including mortality. 2 studies have shown this data. If you take a look about the recent guidelines of the PID released by the European Society, we didn't have any information about guidelines, any information about the approach. It's surprising, but we didn't have information here. Now, if you look from the coronary side, we have since a while, you can see this study, 2008, 2009, we have study in favor of the transradial approach in terms of mortality, in terms of bleeding, in terms of complication, in terms of MACE. And according all this well-done study, level 1 evidence, the European Society of Cardiology released guidelines in 2014, and in these guidelines, radial access should be preferred over femoral access if performed by an experienced radial operator. If performed by an experienced radial operator. First step is to select the patient for radial. And what are the techniques? We can do the Allen test, You can do also some plethysmography tests. It's a Bardo test. But if you look at the recent the literature, non-invasive collateral testing should be abandoned as a triage tool for radial artery procedure, such as arterial puncture, arterial monitoring, and transradial approach. So forget this technique. So if you know, talks about the access site selection and patient setup. First, if you want to treat lower limb, go by the left side because it's shorter. Secondly, you can make the punction with abduction, and then you can put the arm along the side to have the guide wire in the same line as the body, and to perform a routine finale procedure. And adjunctive ultrasound, so ultrasound duplex scan can be used to make the radial puncture. It's very helpful, not just for the transfemoral. It allows to decrease the hematoma rate and to decrease also the patient discomfort. So what I used to do, I do the wrist in extension, not so important, but extension. The palm is parallel to the flow, and I use this needle with local anesthesia with either a single or double wall puncture technique. I use, as I said, duplex scan to do the puncture. And don't forget the cocktail. The cocktail is, which cocktail is not a mojito cocktail? It's heparin, verapamil, and nitroglycerin. And don't forget, because the radial, you can have some spasm. So it's mandatory to use this cocktail when you do the radial approach. So just a quick example, this patient has a right external stenosis. It was not possible because of EVAR to do a crossover, and the retrograde approach was not possible due to the extension of the lesion. So we start by duplex scan to perform the radial approach. It's very easy to do it. The artery, of course, very superficial. We start with a short, not a long, but a short introducer. And then, after that, I put the arm alongside the body, and then I am able to work as I used to work in this case, by crossover, for example. I have not an extra table, to put the guide wire. I just put the guide wire on the table of the hybrid room. So you did the punction. Now you have to work. And what I used to do, I use a slender or hollow one introducer, short one, so 5 or 7 or 6, I mean. And then I go with a 035 stiff guide wire to have maximum support. I use a C2 catheter to catheterize the descending aorta. And then I remove the catheter and the short introducer to use, in this case, a long introducer. Which is very important is to have a hydrophilic introducer, because if it's not so much hydrophilic, it could be painful for the patient. So Cook introducers are pretty hydrophilic. I don't like this introducer, for example, to perform crossover, but to do this procedure is pretty useful. Which is very important also is the length, and of course the size, the diameter. But about the length, in fact, if you have to treat visceral arteries like celiac trunk, SMA, whatever, go for 90 centimeter. But if you want to treat iliac, CFA, and SFA, use a 110 centimeter introducer. You should also keep in mind that since several years, many improvement has been done in terms of introducer, in particular this thin wall introducer. You can have an example here. The main introducers are from Terumo and from BD, the hollow one and the slender, but the slender is not available in long length. And you can have, for the same inner diameter, a similar outer diameter when you use a 6 French thin wall in comparison to a standard 5 French. So it's very useful in this case if you go by the radial axis. So then you have to navigate into the radial artery. It's a regular radial bifurcation, brachial bifurcation here. But in some cases, you can have high radial bifurcation. And so if you have any trouble do not hesitate to make an angiogram, just to check where is the bifurcation. Also, you can have many tortuosity at this location. Again, don't push. You use a 035 guide wire. Do it gently. And if you are not successful, make quickly an angiogram to check. You can have, in some cases, terrible loops, and so at this time, you give up and you change the access. Also, everybody knows here that we can have also some anomaly at the ascending arch level, and so in this case also you should identify this anomaly. After the approach, you have to cross to make the vessel preparation and the treatment. Keep in mind also that the regular length between the radial approach and the CFA, it's about 135 centimeters. 135 centimeters. And so we didn't have so many tools to just make a catheterization. Most of the catheter are about 110 centimeters. So we didn't have so many tools. Also in terms of vessel preparation, in terms of device treatment, we didn't have so many long devices. So keep in mind that you should have this long shaft to cross, to treat, and to treat the patient. Also, of course, because of the length, you lose in terms of pushability and navigability. After the procedure, after the treatment, I mean, you have to make the hemostasis at the location of the radial. It's pretty easy. You can use a pad and bandage. You can use also some adhesive hemostatic pressure pad, and you have also some classical radial compression device to perform the hemostasis, and it's pretty easy to do it. And you have very few complications. In the literature, I find some contraindication to the transradial approach. It's about severe vaso-occlusive disease. It's about documented small radial artery. It's why if you use duplex scan during the appointment, in the preoperative appointment with the patient, use the duplex scan to check the size of the radial artery. And we did not know so far the impact of this approach for the future AV fistula and the future coronary bypass using the radial artery. In terms of advantage, and it's my main indication in my routine practice, is contraindication as a transfemoral approach. Before the radial approach, I used to perform brachial approach, and I experienced by percutaneous approach at the brachial level some complication, and major complication, nervous complication, but also bleeding, hematoma. And it's why, in this case, I prefer to shift to the radial approach if I need upper limb approach. Also, the main advantage is the safety of transradial approach, as I said at the beginning of this talk. Some people also ask to increase the outpatient rate, hospitalization rate, by using radial approach. I can share with you that I use to do outpatient hospitalization since a while by femoral approach, and I didn't experience with the closure device complications. So for me, it's a bad reason. Like each technique, we have some disadvantage. We have the risk of crossover, as I said. We have to have, in fact, a huge volume of patients. Some people estimate that you should perform first 50 cases and then almost 80 cases a year to be well trained to do this technique. Thirdly, few dedicated devices are available to make the catheterization or the treatment. We lose in terms of navigability and pushability. And also, we can have some problem in terms of radiation exposure and contrast volume using this technique because you have to make some catheterization at the upper limb level and the descending aorta. So to conclude, Allen and Bardot tests are not required anymore. Duplex scan facilitates transradial artery approach. Don't forget to use a cocktail with heparin, verapamine, and nitroglycerin. Dedicated devices are required also, and major complications after transradial approach are uncommon. Last word. When I leave Paris and I go back to Nantes, it's my routine life, I can first go my friend Koen Deleuze in Belgium, Then I can go to Burgundy, drink some white and red drink of Burgundy wine, fantastic. Then I can go to the sea, to the Marseille and the Costa of Marseille, and then to say hello to my friend Eric Ducasse in Bordeaux, and then coming back to Nantes. But what I used to say, the shortest way is often the best, and so usually when I go to Nantes, back to Nantes, I go from Paris by train directly to Nantes. Thank you for your attention.
Thank you, Jan. You can stay here. Jan, come back. You can stay here because we have then time for discussion. I think there will be a lot of questions for the radial approach. Now, next speaker is Dr. Soga, that is going to talk from Japan. He's going to talk about another hot topic. You can take this one. It's the current situation of drug-coated balloons. Please.
Thank you very much for kind introduction. Good afternoon, ladies and gentlemen. I'm Soga, interventional cardiologist from Far East Japan. Today, I'd like to talk about the current Japanese situation of the DCB. Before talking my topic, I'd like to show you the number of endovascular procedure in Japan. Just the number of endovascular procedure has been gradually increasing in Japan as well, more than 40,000. Yeah, many cases was down. Here is the institutional volume. The entire endovascular institution is around 800, but high volume center is quite a few, so more than 7 cases of the endovascular procedure was a couple of, institutions. The mean volume endovascular procedure is around 50 endovascular procedure a year. This is a Japanese situation. Let's talk about the current Japanese Femopop endovascular procedure situation for 6 years. So before 7 years ago, so we don't have the DCB, therefore, so we treated with the balloon angioplasty or bare nitinol stent. But for now, after the approval of the drug-eluting stent and the drug-coated balloon, so especially drug-coated balloon has been widespread in Japan all over Japan. So nearly, maybe last year, or more than 60% of the endovascular procedure was performed by drug-coated balloon. They're very special. Maybe they're very different from the Western countries. So first of all, I'd like to talk about the Japanese very specific, special DCB situation. DCB is only commercially available for the Femopop lesion, no BTK. We don't have the DCB for the below the knee, just only Femopop lesion. So also commercially available DCB is only 3: Ranger, Impact, the Lutonics. The Ranger and the Impact is very popular in Japan. All kind of DCB is the same price, does not depending on the balloon length or balloon diameter. So all shorter one, the longer one, all the same price. So also, interestingly, bailout stent is not reimbursed. Therefore, before using the DCB, we have to decide which way to go, the stent or scaffold or DCB after the ballooning. Furthermore, I'd like to tell you the specific situation of in Japan. The endovascular procedure, the 80%, more than 80% of the endovascular procedure was performed by interventional cardiologists. So remaining 20% was performed by interventional radiologist or vascular surgeon. There is no angiologist in Japan, just only 3: the interventional cardiologist, interventional radiologist, and the vascular surgeon. Therefore, so interventional cardiologists they are very familiar with the transradial intervention, so they love the 0.14-inch guide wire and the monorail system. So also they love, including me, we love the iVS imaging modality. So after that, so Dr. Fujihara told you the imaging system. So also we love the true lumen intraluminally approach. This is a Japanese style. I will show you the case of 64-year-old male who had intermittent claudication. The lesion is located in the proximal SFA. So I treated with a DCB like that, so no bad. But we treated from the transradial or transbrachial. It's not special. In some cases, we choose a transradial or transbrachial intervention. Before talking back to the DCB, we have just only 3 DCB. This is a Japanese approval data, the Lutonix, the Impact, and the Ranger. The primary patency is a little bit different among the 3 DCBs. So in the real-world practice, the multi-center large DCB registry was performed, which is called popcorn registry, including the more than 3,000 lesions. I will show you the Japanese DCB registry at the 2-year. The primary patency at 2 years after the DCB was 70%, and the freedom from TLR at 2 years was 81.8%. This registry, including the 2 types of the DCB, the Lutonix and Impact, I think it's very acceptable. So also, bailout stent is less than 5%. So very different from the Europe. Maybe in the same situation, maybe more than 30 or 40% the bailout situation was observed. But in Japan, it's not reimbursed, therefore very lower bailout stent. Here is a subgroup analysis for the CTO that we check by the iVS, the subintimal group and the true lumen group. So primary patency is much higher in the true lumen group after the DCB. They're very different from the teen trial, the very low bailout stent. Therefore, we stick to try to take true lumen. Here is the 2 different of the DCB. The primary patency up to 2 years, the impact is much higher, significantly higher up to 2 years. So the 6th risk factor was found of the risk analysis, the more than 2 times of a history of the revascularization, the lower reference vessel, the severe calcified lesion, the presence of CDO, and the low dose DCB. It means that Lutonix, and the residual stenosis. It's an independent predictor of the stenosis in the Japanese large cohort. There are independent, therefore, so stenosis risk is accumulated like that. Therefore, if a patient has 4 or more risk factors, the 2-year primary patency was around less than 50%. On the other hand, if patient has no risk, no CTO, no calcified, no residual stenosis like that, so hopefully the primary patency seems to be around more than 80%, 85%. So very different in each situation. After that, the Ranger is also approved in Japan. Therefore, we conducted the popcorn type of the Ranger DCB registry, including the more than 1,000 lesion. Here is a comparative 1-year primary patency between the popcorn and the popcorn type are almost same, nearly 75 or 79% at 1 year, the primary patency from the Kaplan-Meier analysis. Let's compare among the 3 DCB. I personally think that DCB is not same. It's a very, it's hard to say, but I think it's not same. The primary patency, the one DCB is lower, the other DCB is much higher. The gradually increasing among the three DCB in each endpoint, the primary patency and freedom from TRL. So let's move on to the near future situation in Japan. So recently, hopefully within 1 year, the next fourth DCB will be approved. Sequent, please, the fifth DCB, the conscious from Terumo RX, the longer shaft DCB will be approved. Maybe next year or next year, the solution from Cordis, the sirolimus drug-coated balloon will be approved in Japan as well. Finally, the seventh DCB, Lumino, will be approved in Japan. Hopefully 2 years later or 3 years later, I'm not sure, but the seventh DCB will be approved. So as I mentioned before, we can use many DCB in the real world practice. The impact is a king of DCB, I think. The Ranger had a smaller 5 French compatible low doors for CLTR, the very convenient DCB. The Secret Praise has a 3mm or 8mm DCB, maybe. The Conscious has a longer shaft DCB, so you're using from the TLI or something. The solution is another drug. It's a very important topic. The Lutonix it's a Japanese specific special 5 French RX 014 compatible 300 DCB will be available in Japan. They're a little bit different, but so as well as the Lumino, so it's very hard to select the DCB for just one Femoropopliteal. Thank you for your attention.
Okay. Thank you,
Thank you.
Thank you, Dr. Soga, for this presentation and those excellent registries. We'll make the transition with the next presentation. The next speaker is a young rising French star, Professor Ducasse, coming from Bordeaux. And he will talk about the real-world data, why it is important.
Thank you for the young raising. I'm not sure. Anyway, thank you. May I have my slides? Yes, please. Thank you. This drug technology is there a sort of inequality in terms of procedures? Because that has been mentioned, the crossing really cares, and also the predilatation, and also the angioplasty, I think, in terms of sizing, in terms of timing, and also, now from the recent years, also the adjunctive treatments we may have, like the debulking or using the IVL before using the drug technology. All those may have influence. Also, in terms of support regarding the drug technology, we have, also, of course, the DCB, but also the drug-eluting stent, and also that have been mentioned, the use of first the drug-eluting balloon and after to scaffold the artery. And also in terms of drug that have been mentioned with all our taxes, this is paclitaxel, but is also raising the limus, the use of sirolimus. We use it for the BTK, but that could be a challenger also. Thus, what are the strong evidences? First, PTA is also associated with 4 main failure mechanisms that are dissection, that are residual stenosis, mainly due to fibrosis or calcium, recoil, and also restenosis, that could be immediate or during the follow-up. And restenosis, what is so-called due to intimal hyperplasia, is always a biologic response to inflammations. And that's why it's dedicated the drug to be avoided. This is, and that has been proven, especially using the scaffolding support. I mean the drug and the use of drug in stent. This is drug in stent, that are superiors in terms of patency, target lesion TLR, and also in terms of clinical improvements. Thus, drug, it's maybe not only, this is only to avoid restenosis due to intimal hyperplasia, especially for the use of the DCB. Thus, RCT have shown clinical benefit using drug-coated devices, especially for patients undergoing FEMPOP, maybe only FEMPOP procedures. Nevertheless, RCT enroll a very highly selected group of patients with very strict indication and very strict contraindication. And maybe the results cannot be fully extrapolated to our daily practice in terms of treating all comers and all the patients that we treat in our cath lab. That's why, and this is the, how is it organized? This is the top of the top. Of course, this is the meta-analysis. After there are the RCT, but maybe the cohort and registry, especially with large included numbers, may have very significant influence or determine what could be the best technique or the best device to be used. We know regarding the stenting, the drug stents, and since the recent Saval for BTK failed, and also Battle for FEMPOP failed versus the non-elated stents. For the use of the DCB, that have shown some superiority in terms of RCT, but once again, patients were very, very and strictly selected. But also, this is the way of the registry, and I want to report the result of the LumiFollow, that is the use of the luminor and only dedicated for the FEMPOP lesion, including large number of patients. Here are the inclusion criteria that are quite very large. And for example, you see the Rutherford classification that almost all the patients were included except the Rutherford 6. And also regarding the angiographic criteria, that's of course stenosis, but this is a class A to D task 2 classification. And what is important in our the patient we treat all the day, that's only there are de novo lesions, but there are also patients with previous stent implantations. And you see that some of those patients are recurrent treatments. And regarding the lesion, this is from proximal margin of the SFA, the diasteum of the SFA, but down to the P3 segment. After, here are the exclusion criteria, quite very, very basic. And this is the primary endpoint. This is for the safety and moreover for the patency. The patency is defined as freedom from TLR and also educated, validated standard based on the Frischel ultrasound investigation. Thus, here are the centers. Once again, that was only French centers. And these are the numbers of patients that have been included. This is a large number of patients, more than 500 patients have been included. We are still compiling the data, and we will have soon the final data at 2 years. That's our preliminary data. You see majority of men, and you see that more than 40% of those treated patients were with a diabetic status. And you see here that more than 1/3 of those patients were with a stage 4 or 5 in the Rutherford classification. That really makes sense in the patient we treat once again in our daily practice. Thus, here are the lesion characteristics. You see that almost 15% of those lesions were popliteal lesion. That's once again, that makes sense. And here, 1/4 of those treated patients were not de novo patient and lesion that receive previous treatment, all by angioplasty and some with some stent previously implanted. Here is the mean length of the lesion. This is 13 centimeters, the mean length. And this is the numbers of CTO that you see they are a very worse lesion with 45% of those lesions that were fully occluded. Thus, this is the numbers in rate of patients that have been with predilatation. I thought that was all the patients. Finally, 10 of those patients didn't receive any predilatation, but a direct DCB angioplasty. And this is the necessary post-dilatation after the use of the DCB. And this is the numbers of residual stenosis. And what makes sense, you mentioned that versus the Japanese style, this is a number of provisional stenting that is quite important in our current practice in France, but is fully reimbursed, and maybe that make the difference with the other countries, because 43 of those patients after the DCB treatment receive provisional stenting. It's half a tin procedures, in fact. Anyway, after that, this is the number of lesions that have been treated. You see that 1/3 of those treated lesions have been crossed using an 0.18 inches guide wire versus the basic 0.35. And you see the mean length of the balloon used. Once again, that was 13 centimeters, the mean length of the lesion. And this is the mean length of the provisional stenting that have been added after the DCB use. This is the complication, and this is the all causes death at 1 year. Thus, these are the results. These are the results at 1 year, and these are the results at 2 years in terms of freedom from tear. That it's quite impressive. You see that 95 of those treated lesions are free from any tear, and maybe it's due to the scaffolding and provisional stenting. I do not have the answer, but this is the main difference regarding the technical aspect. And you see that it's also very good at 2 years. That's the use of the luminor, and maybe an intensive use of provisional stenting is very efficient in terms of freedom from tear at 1 and also at 2 years. And this is the freedom from TVR, also very, very good. This is linked, but anyway. And you see that this is the clinical endpoint. You see the evolution in terms of the Rutherford category. That's almost of the patients are in Rutherford category 0 or 1 at 1 year, and also remaining at 2 years. Thus, this is the medication that is used. To see that's some fold on in terms of antiplatelet medication. Anyway, and when we compare to Tintin, that is the use of the DCB, not provisional, but in all the cases scaffolding. That makes sense. That makes sense. We have exactly the same numbers at 1 year, but also at 2 years. And that remains excellent for the Tintin at 4 years that have been reported. Thus, real-world data and RCT continue to confirm the long-term clinical safety and moreover effectiveness in terms of the use of the DCB, especially in the FEM population. That have been reported also for the CTO. It's worsening for the longest lesion, and it's almost worsening for the instant stenosis, especially for the Tosaka-free classification. Once again, you mentioned our good friend Katsanos, but there is no safety issue reported in any of the courts at 5 years. We had the same experience in that registry. There are some multivariable predictors of reducing the effectiveness of the DCB. This is residual stenosis. This is, of course, the worst lesion and the worst Rutherford category, and also the very thin arteries. And the longer lesions were more commonly treated with, once again, provisional stenting, and the luminal depth in real practice SFA treatment performed once again with real excellence. Thank you for your attention.
Thank you, Eric, for this very nice overview of for real world. Now it's a pleasure for me to introduce Dr. Fujihara from Japan, who is going to talk about imaging technique for the femoropopliteal arteries. Please.
Thank you all. It is a great honor to be here and to have this opportunity. So I'm Dr. Masahiko Fujihara from Japan. So today my talk is about current status of the endovascular therapy with the imaging modalities. So iVS. So iVS and iVascular, there's a very similar word. So both is beautiful. So this is my disclosure. So, and recently, the evidence for the iVS has been growing up rapidly. So, search on the PubMed in recent years has turned up the large number of the iVS publications. And some data have been published that show that the EVT with iVS has an impact on the long-term outcomes, not only procedure successful. Data from Japan on the left and right is the latest RCT data. It is being proven to the effect on not only the success of the procedure, but also its long-term durabilities. So, and this is a very interesting data from Dr. Soga, who found that the iVS is cost effectiveness in the long-term durability. And the latest data, last year, the new iVS appropriate use was posted, and so this is our data. So we developed a consensus document with the goal of the standardization of the using imaging modality to make them more correct. So needless to say, iVS is most effective in the femoropopliteal regions. Now let me talk about the current status of the femoropopliteal artery intervention with the imaging modalities. So there are the four main purposes of the imaging modalities for IEVT. So first is the guidewire crossing and the region evaluation, size and morphology, and the device selection and the device size selection. So I will begin with a brief discussion of the guide wire passing with iVS. So iVS is one of the most efficient CTO crossing devices. So it is because it's giving us an accurate image of the guide wire positions within the CTO regions. So I will talk about the four situations to use them. So based on this, CTO guide wire route with iVS can be categorized into the four types. So type 1 system, so where the guide wire and iVS go through the intimal space. And type 2 is the integrated guide wire into the subintimal space, and most one system into the two lumen with the iVS guidance. So type 3, the integrated guide wire into the false lumen. So switch to the retrograde axis and iVS guided into the two lumen by the retrograde axis. And the type 4 is the very complex situation, so antigrade and the retrograde system both is the subintimal space. So here are some examples of cases. So this is a case in the 80 years male, a CTO with the long regions of the 24 centimeters. Finally, the proximal position was treated with DES and the distal position with DCB treatment. So this case is a short tip iVS and all 18-inch guide wire. So the iVS is used to confirm the system in the intimal space and then the procedure and advice step by steps. So if the iVS is shifted to the subintimal space, the wire is used to make adjustment at the point. So this is what it looks like of iBus. So the position B is into the subintimal. So we control to the guide wire while correcting it. As you can see, we have succeeded all through guide wire crossing. And the next case is already with a small vessel who managed to get the guide wire through the old intimal lumen, and I want to treat it with a DCB strategy. So she's a CRTR patient with a poor BTK, poor BTK, so distal puncture portion was not. So I want to true lumen guide wire crossing. But I cannot integrate guide wire crossing. So first guide wire did not catch the ancient lumen and to the CTO lumens, and in this case the support catheter and the second guide wire need to the hurdle when the guide wire can be guided into the optimal location with the two guide wire system. The iBus is switched and checked. The process is repeated. So this is the actual iBus image. As you can see, the second guide wire in the intimal space, and so we carefully proceed with this wire. Thus, iBus can probably guide us along that route. So the next step is to evaluate the region morphology. So this is now discussed in the significant depths. And now the hottest topics in this area, in the SF area. So the latest report from the Australia was so impactful. The first RCT reported improved the long-term outcomes when combined with imaging compared to the angio guide only. So to be honest, I want to release this data from Japan, but this data is very telling. So the analysis of these results proves that the iBus has a greater impact on the DCB outcomes compared to the stent and the PTA. And the key of this study is that the size of the DCB had changed significantly due to the iBus. So and today, this data shows that Dr. Soga mentioned. So this is truly the DCB error in Japan. And compared to the angiography, it is known that the measurement with iBus are the more accurate and the larger assessment. And this data is from Japan. They reported that the DCB in SFA should be sized according to the vessel size, EEM in the iBus, and that the larger size selection contributes to the long-term patency. So this is consistent with the RCT mentioned above. So in other words, so it is important to measure to EEM has a vessel size, while the bet is quite difficult. So in fact, even specialties with some experience have the large margin of the error. In this case, the yellow line the correct EEM as vessel size. So I will share one sample. He's a claudication patient, and he had severe stenosis in the mid portion of the right SFA. I treated this area and treatment. QVA angiography in the shown to the right. The green line, the green line is the distal reference vessel, which was 4.7 millimeter by angiography analysis, but perhaps 5 dB is enough. So iBus analysis, the EM size reference vessel is sampled at 6.5 millimeter. So I directed with a region with a 6 millimeter DCB. The result is quite good. And this is another important parameter on the DCB strategy, the minimum lumen area after the DCB dilatation. So the post-operative minimum lumen area is so crucial. So the larger, the better, but its cutoff value is 12.7 millimeter square after the DCB strategy. So the post-treatment area in this case was the 14.7 millimeter square. It means that a good patency can be expected. So changing the topics, the iBus finding after DCB depend on what DCB is used. So on the left side is the iBus image after PT, and the right side is the iBus image after the DCB. So first in impact. So a clear white band can be seen after DCB. So we call this the impact ring. So another DCB. So this is Rutanix and the Ranger. and sequent DCB. So these three rotor DCB didn't catch the something to the after the DCB image. So how about the luminol? This is the pre-luminol and after the luminol. One more case. So the DCB band is not clear as an impact link, but it is relatively clear in the iBus after the luminol. So we will call this the luminol reaction, so we can clearly see where the drug was coated. However, among these thrombotic regions and calcified regions have yet to find a clear solution. I think iBus should also be the tool to solve some remaining problems. How do we choose the devices? iBus is another useful assessment tool for the calcification. So in our consensus document, we made it. So we have categorized them into the three patterns: superficial and deep calcification and nodular calcification. And now we have the highest resolution imaging modalities available, OFDI. OFDI has 10 times the resolution of the iBus. So this figure shows that the basic image iBus and the OFDI very clear. And the three-layer structure of the vessels, which will not be visible on iBus. So, but the OFDI can the intimal and medial and adventitious. So we are considering that the best classification strategy in the three classification of the OFDI. And the OFDI can also evaluate the thrombus patterns. So red thrombus or the white thrombus. So red thrombus is more difficult to dilate and more easily distal embolizations. I'm sorry. And the OFDI is good with the vascular dissection after the baranoplasty. So where the dissection is the intimal or the medial is important information for the next steps. So finally, I will share the luminol case with OFDI. So dissection limited to the intimal was observed, but it is well dilated. So origin has been the result of stenosis for 2 years. So this is my summary. The role of the catheter-based imaging modality in peripheral interventions has been gradually increasing. However, the standardization of the evaluation method is still insufficient and remains challenging for the future. Thank you very much for your attention.
Thank you, Dr. Fujihara. Please come here. So, thank you for the results. If the studies shows that when we use iVS, we avoid mismatch when we treat balloon or DCB or something. Any question in the room? Who have access to the iVS? Who use iVS in daily practice? Please.
Small. Minority.
Maybe it's a question. Maybe it's more a question of price and reimbursement because it's fully included in the price in Japan. That may explain. And I think this is very the two main problems of the use of iVS. This is firstly the cost, and also it's time consuming. But after that, this is very helpful for. You mentioned that because one of our good friends is using it. It's very, very amazing, especially for crossing, for remaining central luminal, and to go to cross step by step. It's very helpful. And after for checking and sizing, that could be also very, very interesting. But we use it very, very in a low rate because it's very, very costly.
In Japan, do you use iVS for each FemPop procedure?
For all lesions?
Yes, so yes, fortunately, so we can use the imaging modality and full covered health insurance. So, but depend on the regions. So from our data, so autoiliac disease is not so good impact for the patency outcomes. But SFA is very useful, and Dr. Soga reported that the cost effectiveness from the midterm analysis. So because of the iBus tell us the true story with that, so avoid the TLR or so something.
Let me ask you something.
Yeah.
Do you use the iVS for each single steps of the procedure, or you do just at the beginning and at the end?
Yeah, depend on the opinion, operator's opinion. So in the, of course, in the CTO region, so guide wire crossing is the first use. But my opinion is the baseline analysis and so so DCP strategy, so post boundary plus the analysis and final analysis, so 3 times.
Okay, because there's a question from the audience. Can you bring the microphone? Yes, please.
Thank you, Dr. Fujihara. Just one question. When you address CTO of the SFA, for example, do you use a rapid exchange probe or over-the-wire probe? And do you use your probe as a microcat, or you use it on the false lumen, for example, as a guiding tool to reach the true lumen?
Yeah, yes, it is also so that depend on the region characteristics. So that we can use the 3 types iVS. So very clear image. So Telemos one, the Boston's one have the very clear image. So high definition iVS. So very clear image. But so sometimes the iVS catheter is not so strong, so easy to block. So for example, so that very tortuous crossover axis and the heavy cultural regions. So I use the Volcano, so Philips one. So because of the very strong catheter and so very assessment of the CTO regions.
Dr. Deleuze, please.
So I probably going to be a little bit more controversial to my good Japanese friends because I'm not so in favor of iVS. And I'm going to tell you why. I agree that probably you can improve your procedural success rate, passing, recanalization. I'm not so unhappy with my recanalization rate without iVS. Second, it's very helpful, I've noticed, for sizing your DCB and whatever. Once you know this, that you probably need to oversize a little bit, you take this in account. I don't need to have an expensive iVS for this. To see if it is dissected or non-dissected, okay, I can also notice this on my angiography. The thing I need to know, and that's my problem every day, is it a flow-limiting dissection, yes or no? I want to get dynamical information, information about the flow. I'm interested in the flow, not in beautiful or ugly images. I'm not a plastic surgeon, I'm a vascular surgeon. So I'm interested in flow. So can we, with iVS, on one or another way, can we measure flow to say, this is a flow limiting dissection, you need to stent. This is a non-flow limiting dissection, you can leave it like this.
Yes, that's right. That's I agree with your opinion, but so more information from iVS is very useful for the successful treatment. So because of the, so in the CTO region, so the only the angiography assessment is so very so more longer dissection or the more long so re-entry point is more so disturbed. So iVS is so one more eye, so the third eye for the operators. So I think the improve the iVS analysis can be the more good clinical success and technical success. So, but yes, you mentioned that the cost and so balance is I think so. But yes, so more deep data show us our good in vascular therapy, and we have to switch back to the angiography analysis from the iVS. So it is my future topics.
I think something, you know, I have to disclose, I love iVS. I'm doing in all cases. But I agree with you that we can do also complex cases without iVS. You know, also 20 years ago, we were able to communicate without a mobile phone, but now we are using mobile phone. So it's something that is a plus in your practice. Regarding the flow, the evaluation of the flow, we know this is the big limitation of iVS because you are not able to evaluate the flow velocity. There is a software, there is the ChromaFlow that gives you the option to see some colors that are corresponding to the flow. So this gives you an idea if it is a flow limiting dissection or not. But I agree with you, if you want to evaluate the flow velocity, you have to put a probe outside and measure with a standard duplex.
Maybe a last question for you, Eric. Since the Katsanos meta-analysis, we tried to show the security of DCB. Maybe it's time now to show the efficacy of the DCB by showing non-inferiority or superiority compared to the drug-eluting stents or bimetal stents, because we do not have any data about that. Maybe sports study.
We have results, and we have results, of course, on safety right now, and also on efficacy. But the main problem, I think, this is the multiplicity of technical possibility, and that have been mentioned because, of course, we have the DCB, but we have the DCB plus provisional stenting. We have the DCB plus the tinting, the post-angioplasty and the post-DCB stenting. We have debulking first, DCB afters, and we do not know the value of all of those different technical aspects, and maybe we won't have. We are still running in the good way and making progress, and once again, the use of DCB. What we have learned the most regarding the use of the DCB is not the DCB itself. This is the vessel prep, the long angioplasty to avoid any residual dissection. After that, the answer for is there avoiding a lot of intimal hyperplasia reaction and restenosis. We do not have, frankly, the answers, but we know that we progress. We were starting from 80% of freedom from TLR, jumping to 80, and now we are 90% of, and 95% at 1 year, 90 at 2 years. That makes sense, but we are still in the way of the progress, and I'm not sure we will have a strong answer, but we are still progressing.
Well, just a small question, a quick question to Jan. If in the future you will have some devices with a long shaft, 200 meter, 150, you will use more the radial approach? Yes or no?
You know, I am lazy. So I choose always the shortest way. I don't imagine to make, you know, 1 kilometer to make 5 kilometers if I can do it by 100 meters. So if it's not possible to make the shortest way, I make the longest way. But I'm lazy.
Yeah, but you know, more and more people are using the radial approach and are looking for a longer device because, you know, for the visceral arteries, it's very good. Peripheral, maybe we can.
Yeah, I agree about visceral artery for different reasons because of the geometry of the visceral artery could have some very good indication. But at the same time, you know, with the tour guide, for example, the femoral approach is still. But my message for radial, PID interventionalists should be comfortable with this approach because it's safe and it is helpful. So my message is not to make in routine practice radial approach because, again, I am lazy.
Nothing is.
But if you do PID, do radial approach, and you should know this approach. Absolutely.
Yeah, I agree.
For that, begin with the visceral arteries.
Yes. Good. I think we can close. Yes, we are almost on time.
Thank you.
So we continue with the last session today is about clinical cases, clinical experience change. This is a special session today and tomorrow, just for is a competition session because we have the opportunity to vote the best presentation at the end of the session. We have an automatic system, automatic voting system by the phone and following the instructions on the screen. I don't know if this already there. No. So it's a QR, and then you need to, scan the QR, and then you can be linked with a web page, and the web page is to vote. Then we can start with the first one. So the first speaker today is Arnaud Gersman. is please from Belgium about the ZRAP for in-stent restenosis. Thank you.
And also to thank Medical Company, who is the distributor for iVascular devices in the south part of Belgium. So this is a simple story of a 59-year-old woman. She used to smoke, she had arterial hypertension, dyslipidemia, emphysema, she had left adrenalectomy, varicose veins treatment on both legs, and she had 40 months earlier wide common iliac artery stenting with a bar metal stent in another hospital. She had as medications calcium antagonist, aspirin, statin, and ezetimibe. She complained of intermittent claudication, Rutherford stage 3, on both calves. Walking distance was not precise, but was too short, and was worse uphill. She had palpable pulses, both sides, and ABI was normal both sides. Here is the CT angiography. You can see that the infrarenal aorta is dilated, and after that quite small as the aortic bifurcation. One of vessels are good. So first of all, the stent she had 14 months earlier in the right common iliac was also into the distal aorta. You can see here. And second, the stent in the right common iliac was quite thin and seemed to be stenotic. So I decided to go for CRAP with the following strategy: spinal anesthesia, 6 and 7 French sheets into both common femoral arteries, normal hyperionization. The plan was to use eye cover 10 millimeter into the distal aorta and to make a post dilation with a POBA of 12 millimeters, and then to put 6 or 7 millimeters eye cover stent in both common iliac arteries, and to use closer devices. So the 6 French sheet was inserted into the right common femoral artery and the 7 in the left side. First, angiography could show that there was a stenosis in the proximal part of the stent in the right common iliac artery. So I deployed the 10 millimeter eye covered stent into the distal aorta, and before post dilation, I introduced the Oceanus balloon of 12 millimeter on the left side, and I pushed the 10 millimeter eye covered stent higher in the dilated aorta. So I had to go inside the 10 millimeter balloon and to pull it more down again at the right place. After that, it didn't move anymore. And this is the last dilation with the 12 millimeter balloon. And I deployed 2 7 millimeter eye covered stent in both common iliac artery in a kissing fashion. Post-treatment angiography were good on both sides. There was no operative complication. The patient was discharged on the first post-operative day. She had improved working ability, and Rutherford stage was 1. She had still palpable pulses on both sides, and ABI was normal on both sides. After 7 months of follow-up, she had no recurrence, and she was very happy. She had, after 7 months, abdominal CT for another reason, not for vascular reason. And you can see that the covered stents are right in place in the distal aorta and both common iliac arteries, or under the dilated portion of the infrarenal aorta. In conclusions, the normal clinical examination doesn't exclude PAD, and a new generation covered stent may be deployed into the distal aorta, for example for CRAP, with safety and efficacy. Thank you.
Okay, very nice. Good. Do you, because the IBI previous to the operation was 1 or 1.1
yes.
previously, with some distal pulses even. And what do you explain that? Because probably it's a hemodynamic effect. When it's walking, you can then worse the symptoms, no?
Maybe. The ABI was measured at, when she was still, not by walking. So maybe by walking on the right side, it would be not
then
normal.
my question is, do you perform the walking test in those particular cases?
I didn't do it. And
no?
To be honest, I never do it.
No Strand's test. Okay. Who is doing the Strand's test for claudicants? Nobody? One? Very few patients, very few doctors here. Okay, I think it's good to have it. It's very non-invasive test. I think it's a good, just to make some kind of diagnosis, discharge. Yeah. You can probably you can differentiate from other kind of claudication origins. Okay. Any questions?
You use iCover stent for the aorta.
Yeah.
Yes.
You use a 10mm stent iCover, and you enlarge to 12.
Yes.
According to the IFU of the iCover, are you in the IFU or is it the maximal enlargement of the iCover?
I think I'm in the IFU, and I think it's the maximal dilation in the IFU. But I already did it with a 14 millimeters balloon.
That's true. Yeah. IFU is up to 12, but you can increase up to 14. Yes. Yeah. Any questions or comments from the audience? It's hard to see the audience here.
Last question?
Yes.
A quick question.
Yes, a quick question. Yes, congratulations. Just one. We talk about a young woman who is 59 years old, which has an aneurysm above the stent. No, so the next 5, 10, 15 years, what will be your plan? Open surgery?
For sure.
Open surgery could be the solution? Could be one of the solutions? Okay.
Keep in mind that at 5 years, for PID patients, including claudicants, a mix of CLI, if you go to the national data of a country like France, at 5 years, 45% of these patients are dead. 45. Okay, thank you, Arnaud.
Okay. Next.
I have a pleasure to call the next speaker. I am sorry for the pronunciation, Dr. Wong Shan Shan. And you are going to show us a case of iliac aneurysm.
So thank you. It's been nice to have been here in this fantastic symposium. So I share a case of an iliac aneurysm who is an 82-year-old man who initially presented to a urologist for hematuria workup. And then they did a CT urogram and found the incidental findings of a right common iliac aneurysm, which is 6.5 centimeters. And there's also bilateral internal iliac aneurysms. Although the patient has no symptoms, but then the CT report also showed that there's some radiological signs of impending rupture. So we planned for an endovascular approach for him. So we decided to do a bilateral IBD for him. So first we started off with an embolization of the inferior mesenteric artery, which is 5 millimeters. So we put in a microvascular plug. And then we start off with the right side IBDs in the usual manner. So you can see on the angiogram, the course of the internal arteries is actually quite tortuous. And even after we put in a stiff rosin wire, we cannot straighten up the tortuosities. Okay, so this is the slide on the summary of the angiogram. So, and I guess most of you will use a long wire band stand in these cases, but however in Hong Kong we don't have Gore products. So, and the self-expandable cover stand like the Cufra is, I think, is relatively quite stiff shaft, which is hard to push through this tortuosity. So what we are doing is we put in a balloon expandable eye cover stand, which actually offer a very good pushability and trackability. So in the end, we need to use 5 eye cover stands, ranging from 10 millimeters and some 8 millimeters. The 8 millimeter was used mainly because of the stock problems. We don't have a very stable stock of eye cover at that time. And then we do post-dilatation with a 10 millimeter balloon. Okay, so you can see the eye cover stand actually conform to the tortuosity very well. And then for the left side, it's less tortuous. And then we put in 2 B-graft plus stand. Okay, for the rest of procedure, we just proceed with a standard EVA placement with a main body and bridging stand, followed by balloon molding. And then this is the final images. You can see there's a exclusion of the eyelid aneurysms and preservation of bilateral eyelid arteries. There's some minimal type 4 endoleaks, and we decided for observation. The patient recovers well, but then he has some post-op low-grade fever, which likely to be some post-implantation syndrome, and was discharged on day 7. Okay, so here's the CT findings. You can see the aneurysm was excluded. There's no more endoleaks, and then we can see that actually the eye cover stand actually conforms very well to the tortuosities. So in conclusion, the bilateral common eyelid and internal eyelid aneurysm could be safely treated with IBDs, even with short common eyelid arteries. And then we need a stand graft which has a very good tractability and pushabilities, especially to combat some very tortuous anatomy like in this case. And personally, I preferred a double layer stand graft because we started to see some previous case which we use a single layer stand graft for the IBDs and start to have some endoleak, and then it's because of some fabric fractures over the single layer bare stand, single layer cover stand. So eye cover with a double layer bare stand is a preferred choice in these cases. So thank you for your attention.
Thank you. I have a comment or question. Did you consider any self-expandable cover graft for the right side? Because it was 5 stents you put there.
Yeah.
Probably too many. Yeah, they had to repeat the action many times. Yeah. Probably with the longer Biavan, for instance. I don't know if your country is able or not able. You have Biavan in Hong Kong?
We have, for self-expandable, you mean cover stand or bare stand? Cover stand, then we probably have a fluency and cover.
No, fluency probably is not the best scenario.
It's too hard to push through. So
okay, it's amazing how you perform the eye cover there, but probably long self-expandable, you can simplify your
hopefully
intervention.
We can have a longer self-expandable stand.
Any comment or question? No? Clear. We move on. Thank you very much. The next, Dr. Jürgen Thorsten Berpsit is talking about the long lesions treatment. From where? Abdominal, iliacs, SFA?
SFA.
No,
SFA. Hello to all of you.
The previous one. It's a... Oh, sorry.
Okay.
Yeah. Go ahead.
So I thank you for having me, and the request was especially to underline the tinting concept for the treatment of long SFA lesions. So I have a rather simple but typical case, a male, 79 years old, with increasing claudication, Rutherford classification 3, with a typical vascular profile. And when we made an MRA scan, you can see treatment was here, the right leg. You can see a severely diseased and partially occluded SFA. So outflow was quite okay, but the question was, how do we tackle this problem? So who, in this case, would choose for a bypass? No one. I'm surprised. Yeah.
Maybe myself, why not?
Okay.
Yeah.
So reasons to do a bypass might be you think it's technically not possible, or you say it's, I think the results in the long term aren't good enough, or maybe for financial reasons. But we were involved in the Tintin trial by our friends of ID3, looking at task C and D lesions, long lesions. And the idea was to evaluate the safety, but also the TLR and patency rate of a combination of DCB and bare metal stent. And so it was a Belgian study in multiple centers. So pre-dilatation was mandatory, using either a 35 or 18 platform. We came from the contralateral side. Who would approach this ipsilateral? I think, as was mentioned before, could be an option, but as was mentioned before, it's very important to have a good inflow. So if the lesion comes high and very close to the common femoral, your sheet shouldn't be a reason to leave the proximal SFA untreated. And for that reason, I think a contralateral approach makes sense. Then I use a 018 guide wire. In my experience, this works better to get re-entry than an 035 and 018 support catheter. And as you can see, we managed quite well to get re-entry into the popliteal artery. And then we did a pre-dilatation using a 4 millimeter, 20 centimeter balloon with this result. Quite nice, but also a quite nice spiral dissection, as you can expect in this type of long lesions. And that's a little bit the concept of the Tintin trial, that you know that in this type of lesions, most of the time a balloon won't be enough. There is a very high rate of bailout stenting, and so using DCB and bare metal stent does or should make sense. So we use the DCB, Luminor 5200 and a second balloon 5150. And then stent implantation in this trial was mandatory. So you can see the whole SFA stented, and post-dilatation wasn't necessary, wasn't mandatory. We did it in this case. And if you look at the completion angiography, I think we can say this is a nice result with a good outflow below the knee. And so I think two things I would tell you. If you say I do a bypass because of technical reasons, you should try. But if you try, make sure, one, you have enough material, different guide wires, catheters, enough balloons, stents, and so on. Secondly, I always disinfect the whole leg in this type of patients. It never should be having the leg not prepared to come from below and whatever. Should never be a reason to abandon the procedure and stop the procedure. Second thing, when it comes to the results, the long-term results
the conclusions.
were already mentioned, but primary patency, TLR, survival was mentioned, but also the clinical results are very good. And so also this should not be a reason to not to try to treat this type of lesions endovascularly.
Thank you so much. Is the total occlusion one of the criteria to apply quite often the stents, or just if you have a nice result with a balloon and drug-eluting balloon could be enough? The occlusion makes some kind of differentiation in your stenting?
I think that if you have an occlusion, and we have data on that, if you have an occlusion, the bailout ratio goes up. But especially in this Tintin trial, stenting was mandatory. So here there was no discussion.
Outside the Tintin, outside the trial, you perform always in front of...
Outside of the trial, if you have a very nice result, then we do no stenting or a spot stenting if necessary.
Okay.
But this is a Tintin trial situation.
In your case, you use 5 or 6 millimeter diameter DCB?
This was 5 millimeter.
So you make the vessel preparation, downsizing a little bit by 4 millimeters, and then you use a 5 millimeter DCB balloon.
Yeah.
Okay.
Yeah.
And what was the duration of the inflation?
3 minutes.
3 minutes.
For the DCB. 3 minutes.
For the DCB. Yeah. Is it the IFU of
It's less.
It's less. Huh? It's 1 minute, I guess. Huh?
It's 1 minute is the lowest range. Yeah. Kun.
You mentioned very short but clear. In my hands, I have more success to re-enter with the 018 wire catheter. Why is this, you think?
I don't know. But my impression is that if you go with an 035 guide wire right from the beginning, as you showed in a case as well, you get this huge loop. And for some reason, I think it's less easy for this stiff or wide loop to drop back into the lumen. And so I always try an 018 wire first. And of course, if that doesn't succeed, you can go up to a 035, but I'll try to start gentle, and often this works.
Okay. Thank you so much. To my knowledge, I think it's the Luminor is the lowest duration of inflation for DCB.
Yes, 1 minute.
1 minute. It is IQ. So now we move on to we're gonna to change of location. We go to the upper limb, and I call Dr. Andreas Marin, and so we are going.
Marin is not here. Sorry.
Oh, no. Okay. So it's Dr. Juan Varela.
Yeah.
And juxtarenal artery, I guess.
Marin will present tomorrow.
Okay.
Thank you very much for the kind invitation. This is a 78 years old male patient. He's in the ER recently with 12 hours of abdominal pain, stable, with a pulsatile abdominal mass. He's on aspirin clopy for PTA stent in the last 6 months, past smoker, COPD, and creatinine 1.2. The relevant information for this is an aortic diameter at the level of the lower renal of 37 millimeters, 60 millimeters of that maximum aortic diameter. The iliac artery is 21, another aneurysm in the left iliac artery of 42 millimeters, and the celiac trunk occlusion. So we treat this kind of patient in most cases of juxtarenal and pararenal aneurysm with the semi-sequential deployment technique we developed 3 years ago, in which we cannulate the T-branches and vessel Y. The first stent is kept closed, as we can see here. The first stent is kept closed, and the constriction sutures are kept closed. So we do from branches to semi-fenestration. And our idea initially was to use the branch device as a fenestrated one, downloading the device after cannulating the determinant vessels. This is possible because we keep the first stent partially closed, and we prefer this technique over fenestrating, physician-modified in emergency cases. So our treatment approach was with branch, with I-cover stent to SMA and renal arteries, close the CT branch, embolize the left hypogastric artery, a Gorbel bottom to the right common, and an extension cook for the left external iliac. The access, as you see, is very tortuous. And we modified the device. We prefer to suture a branch that we will not use, in this case the CT. It's quick and cheaper and more secure in the long term than to implant an implanter with the SMA cannulation. And the I-cover is 57, and after cannulate, we download the T-branch to stay very close, as you can see here, very close from the branch to the entrance of the vessels. And this is idea. The expansion of the SMA was stent with 8 by 57, very good, very precise. Then, which is very interesting of this kind of stent, is there is a very good visibility, which is not so common in other stents during and after the deployment of the proximal and distal markers. The same for the left renal, very precise, very visible, the ends of the markers. And with the right renal cannulation, we had some problem, because due to the 90-degree angulation of the kidney with respect to the branch, we were not be able to maintain a high support wire and guiding catheter in the right renal, so we fixed it with the balloon technique from below. So without the possibility to have a guiding catheter inside the artery, it was very important to have the stent with good tracking that navigate well without this guiding catheter, and we were able to do that without guiding catheter. Then we finished the right renal cannulation, and which was important, we were aware of this 90 degrees angulation with the radial force of, with the radial force of the stent. We didn't need the relining stent we were thinking about, but the radial force was so good that we were be able to not use a relining stent. Then we did the coil embolization, the left hypogastric, the extension to the left, the bell bottom to the common right iliac to preserve the hypogastric in the right side to avoid the paraplegia. And the final images are like that. The patient were very well, and we discharged it 3 days after the surgery. And in conclusion, this new generation of cover stents has shown a very good visibility, flexibility, tracking, and radial force in complex aortic aneurysms. It's a very good option in the management of thoracoabdominal and juxtarenal aneurysms with branch devices. We have incorporated them into our stock for these cases, complex. And it's a good option. A good option will be to have them in 79 millimeter length. Thank you very much.
Thank you, Juan. 79 is not in the pipeline. 77. It's
But
just 77.
Yes. Oh, okay.
It's not 79.
Yes, 20 millimeter more would be nice to have it in the stock.
It's 57 and 77.
Yeah, that's
all
it.
right.
Yes,
Good.
yes, of course.
One question for, I saw that you used this kind of maneuver with the balloon for the right renal artery.
Excuse me?
For the right renal artery.
Yeah.
You try to put the balloon before the stenting is passing there without sheath. You are not afraid about this kind of dislocation in this angulated, a lot of friction?
Yes, Yes, it was tough, but we prefer to try to go with the RAM. This is a good maneuver. It's easier to do. The other thing that we can do is to capture the wire and put it as Marcelo Ferreira does. But it works very well. After implanting the balloon, we were able to change from the hydrophilic wire to the high support. We like the 1 centimeter tip from Boston Scientific. Yeah. It's very nice wire, and so we could do the change and good. That we were surprised is we were waiting a kinking, but we hadn't kinking, so we didn't rely on.
There's a kink resistance. Okay. Any questions? No comments? Okay. Thank you, Juan.
Thank you.
We move forward. Another tinting technique of the Gilles Goyot.
So, thank you for the kind invitation and congratulations to iVS for this beautiful meeting. So, if people haven't yet understood what the tinting technique is, we will put the nail in just a bit deeper. Actually, it's not really tinting technique, it's modified tinting technique, so it's quite different from the previous talk. Actually, our patient was a bit younger than the previous one. He's only 78-year-old. Previous one was 79. So his history is a bilateral calf claudication, which was predominant on the right side with a walking distance of 200 meters. Here you can see the angiogram, the CO2 angio. Oops, sorry. Yeah, here's the CO2 angio. Where you can see a long lesion, SFA lesion, with a tight stenosis and short occlusion until the antecanal. And so we treated him through an antegrade approach. We tried to stay intraluminally, and we always use as first guide wire 018-1 to answer to Kuhn as well, because we're used to implant some suprarastan. So we moved to 018 guide wire for a couple of years now. And so we managed to cross these lesions, not so highly calcified, intraluminally, and then we cross. We inflate a lung balloon for 3 minutes at 10 atmosphere with a nice, nice inflation without any residual stenosis. Here is the result of the POBA. You can see proximal dissection here. Good flow at the mid part of the SFA, and then again dissection. So we moved on DCB strategy, and we inflate prolongedly two DCB of 6 millimeter diameter and 15 centimeter length, luminor 18, and this is the final results where you can still hear dissection at the proximal part and also dissection at the end. And so we moved for implantation of 2 short stents, 2 Evolution Pro, 6 millimeter in the proximal part and 4 centimeter length, and 6 centimeters at the distal part. This is the final result with a very good flow, and you can see the collateral there, which inject in the retrograde manner. So it's very good flow and good outflow as well. So we experienced a very nice clinical outcome. We have now 15 months of follow-up, and he's still asymptomatic. He was playing tennis just next to me a couple of weeks ago, and I couldn't experience any claudication with him. So what I think is, in non- or weakly calcified ISD lesions or C lesions, the optimized treatment could be an intraluminal crossing using 018 or 014 guide wire, an optimal vessel prep using prolonged POBA, and the best option, or what we could do best, the lesion treatment with long DCB inflation and then spot stenting to improve long-term outcome. The goal is not to have a nice immediate result, but to have a long-time good outcome. So I don't really believe in the leaving nothing behind paradigm, and I think we should not perhaps oppose DCB and stents. I think both are complementary. And I was surprised when Eric presented the result of the LumiFollow study, where we can see for mid-length lesions, an average rate of bailout stenting of about 42%. That's also the rate we observed in the long SFA lesions. For lesions between 28 and 30 centimeters, it's also a rate of around 40%. So perhaps for all comers SFA lesions, the average rate of stenting to improve the long-term patency and long-term good clinical results is perhaps the average rate of stenting. Thank you very much.
Okay, thank you.
The modified technique, the modified Tintin technique by Gilles Goyot could be called the Tintin technique.
And not Tintin.
So Gilles, can I ask you a very provocative question, especially with Jan Goefic as a moderator? Is this, these results of the LumiFollow, the Tintin, etc., is this the end of the drug-eluting stent? Because DCB and BMS, outstanding results, the Eluvia can never beat this.
One answer.
What do I need to think now?
I think one the answer could be the economic point of view. As mentioned before, in Japan, you cannot use DCB and then bailout stent, so it could be a reason why not to use always BMS and continue to use DES. I know Jan is a strong believer in DES as a primary stenting, but I think in this case we're talking about very long lesions. That means between 20 and 30 centimeters. So I'm not sure the full metal jacket option is really the best one. I think there are very good results for mid-length lesions for the DES, especially the Eluvia one, so for lesions between 8 and 12 centimeters. But it could be probably an option and as a primary stenting option. But for long lesions, I'm not sure full metal jacket is the great option. So
I guess that the discussion is open, but what is sure, the dogma of leaving nothing behind, which was not proven, that's why I call it dogma, is over. And we can show it today, according to LumiFollow, according to what you show. I don't know what is the best treatment so far. We have some data, but it should be proven. But the dogma of leaving nothing behind is over.
Have more questions,
Jan and Gilles, one question. You don't think that the Tintin technique is the only technique that we can perform with an active technology for the 5 millimeter artery? Because we don't have this kind of device with Eluvia in 5 millimeters, sorry.
No,
and when you put 6 millimeters in the 5 millimeters, it's a good choice because you have a drug eluting stent to treat the hyperplasia that will be created by oversizing your stent.
No, I think you are totally right. The main limitation of Eluvia is related to the size. They don't have any 5 millimeter, and according also related to the length of the stent, which is maximum length at 12 centimeters. It's a main limitation for long task C and D lesion, obviously.
Okay, thank you.
Thank you.
For the next.
Yes, this one is here.
That is yours.
I call so Dr. Viander Shirain. Okay, to discuss about iliac. We have some amazing iliac cases today. I was very, very impressed by the case.
A lot.
Go ahead.
We wait for the slides now. Yeah.
It is Gilles Goyot. He pushed a button to avoid the presentation.
You need to use another remote control. No, is this one? Okay.
I mean, the PPT was, the videos were not working, so they shifted to Keynote.
All right. Switch to the Mac platform.
Only the videos are not working. I can show on PPT.
It's a Mac case.
The choice between all the speakers will be very difficult. We didn't see the case of tomorrow, but today it was pretty challenging case.
Okay.
Yes, all of them. All of them, yeah.
Go ahead.
Yeah. So, good evening, everybody. I'm the last man standing between you and dinner. So, my case is a very simple case of iliac stenting. My patient is a 74-year-old gentleman who presented with claudication, more so on left side, and has multiple comorbidities, post-cabbage, low EF, hypertension, diabetes, all routine. So we did a Doppler. CTA was not performed, but on duplex he had a lesion. He was a thin-built guy. So a complete external iliac was occluded with reformation of common femoral. And on the right side, there was a critical stenosis of proximal right external iliac. So the plan was to go with a transbrachial access. Usually, we take a lot of transbrachial access. So a 6 French long sheet, and the left side was the target. And being a hybrid setup, whenever we fail to re-enter CFA, either we take a retrograde access or we go with endarterectomy and patchplasty and then a stent. So that was a backup. So I'll share the images. So that was the ostial lesion, complete cutoff. There was a stenosis on the right proximal external iliac, and there was a poor reformation of the common femoral. But on Doppler, you could easily see it. So the wire went fine. We used a 035 wire to cross, and then it was changed to 018. We have shifted mostly to now a vasculomimetic stent whenever we go very close to the joint. And then the top part is treated with either Self-X or balloon mounted. So that's our protocol. So we crossed, and then we changed to a thinner wire because the supera goes through 018. We dilated it up to 7 mm and 8 mm, and then we took a 7.5 supera, and that it was inlined. And I'll show you the run. So this is how it was. So we know there is a proximal lesion which has to be tackled with balloon mounted stent. So with the same 6 French sheath, as the profile of the restorer is great. We all have seen since the morning that it goes through 6 French up to 10 mm. So we went ahead. The visibility is great, and that's how we dilated it. So this, and then the proximal part was remodeled so that it takes the wall opposition. And then there was a run on the left side. With the same axis, then we went on the contralateral side, and the lesion was pretty small, so we opted with 28 mm length, pre-dilated, and then went ahead with the balloon-mounted stenting. So with the same approach, we could treat both the lesion. So it's a pretty simple case, but with a transbrachial access, we could manage both. On both sides, balloon-mounted stent restorer was used. After the availability of restorer, I think we have shifted a lot to this stent, either eye cover or restorer, because of its visibility, trackability, and good, I would say, radiopacity. So that's my case. Thank you.
Thank you. Did you mention that 500 meters claudication is disabling claudication in your country? Here is different. You need to be more limited in order to be operated on.
100?
Yeah. But I don't know, in France, you treated patients with 500
No claudicants at all.
Yeah, no claudicants at all.
I'm joking.
We treat claudicants for 500
You know, just
meters.
a point here. Claudication is not just about walking distance. If you have 90 years old at home, you know, 100 meters is enough. If you are 50 years old and you are working, if you have a claudication at 400 meters, it could be not so easy to work.
Completely.
So you have also the social point of view to deal with.
And also medical point of view. You need to wait for some kind of educational things.
Of course.
Yeah, because if the patient is still smoking, it's not a good scenario. You have a comment there, Isa.
Yeah, just a provocative question. So this.
So we can end,
So basically, this is so far leave something behind territory, with no doubt about that. But we are increasingly seeing on meetings, social media, a new tendency of just doing IBL or atherectomy on the ilex. So do you guys think, and I acknowledge that there's no data at all, do you think, guys, this is going to change the game or the rules or not really?
Do you have any question?
I didn't get the question.
Answer for that? No?
Dr. Augusto, I didn't get the question. What was the question?
No, I was mentioning that we all acknowledge that this is a territory for stenting, the ilex, no doubt about that. But we are now increasingly seeing conferences and meetings, people treating this with IVL or atherectomy, with leaving nothing behind in such territory. So do you think, and acknowledge completely that there's no data, do you think this is going to change the game or not really?
As of now, I don't think so. Future, I don't know, but stents work great for iliacs and such CTOs, and with dissections, I doubt leaving nothing behind would really work. So as of now, I think I'll go with stenting up. So leave it for iliacs at least.
Okay. Thank you very much.
Thank you. So we have time to perform the votation here. So we have the slide for the QR. Then you need to scan there and then perform your vote. It's only one question about.
So during the vote, don't forget that at the lobby of the hotel at 7 p.m. you have a bus to go to the dinner, which will be a traditional Catalan experience. So I am very happy to have this Catalan experience tonight.
Oh yes, yeah.
At restaurant Can Cortada.
You need to choose only the best presentation for all the 6. Yeah. And send.
Okay, so see you tonight at the Cortada restaurant for the Catalan experience. Thank you so much for all the speakers, all the moderators, and iVascular for this long, intense day with many information. Thank you so much for being here, and see you tonight. Bye-bye.
Take care.